to the 147th meeting of the Board of Directors of Oxleas NHS Foundation Trust. Do we have any apologies for absence or conflict of interest? Anything you heard, Sally?
I haven't had any apologies given to me, thank you.
Okay, we'll go into the minutes of the last meeting, and we'll go through page 1, page 2, page 3, page 4, page 5.
Andy, just one thing from me on page 5, please.
Yeah.
Section 12 on quality improvement is just the last sentence. Rather than the committee also heard, I think we should just change that. The committee is keen to hear how QI work is being shared between directorates. That's one of the things that's on our action schedule, to understand that learning process between directorates.
That's a very good point. And so is that being picked up within your group about how we're going to share across directorates?
Yes, specifically in terms of the learning from quality improvement projects, yeah.
Yeah, good, thank you. Page 6. Page 7, and that's it. Are there any matters arising from there? If not, I flagged that I want to go a little bit more detail into the BAF. We've got 2 downgraded risks on there, de-escalated, I should say, rather than downgraded. We've had long and regular discussions about 136, obviously all our concerns is making sure that there is a routine way of looking at any breaches and actions taken. It crops up every week in our meeting, my meeting with Matthew and other members of the exec, and it does crop up, reassure me, into PQAC, Yemisi, is that correct?
Yes, Andy.
Right, okay, thank you. Right, okay, if we go into the BAF itself, and what I'm looking for what I've been looking for is to not spend all day here, because we certainly could do on this one, but I want reassurance to the board on all the matters that are in there. So if we go into that and look at the particular items themselves, and I'm looking for a response from the exec or anyone else as we go through. So if there are matters that are really causing concern, we need to have a proper discussion. Otherwise, it will be a short and sweet assurance from the exec member. Matthew, I mean, would you be more helpful due to take us through from 1177 and downwards through the BAF, and you keep an eye on who's putting their hands up? Is that the best way of doing this?
I think so, Andy. I've briefed the exec about this, and I think just so we're clear, our intention, often we mention things on the BAF and we say this will be picked up in the course of the agenda. What we're slightly doing today is picking up those issues here just to make sure we're giving the BAF a proper airing, a proper run out. So you won't be hearing from me. That will come up in Azra's update. We're gonna slightly pull some of those issues forward for a brief update from the exec member now, because most of this is covered in committee, etc. reports. But I think we just want that slightly more front-ended discussion about risk. So the first one at 1177, and I think we know Azra and her team have been doing some tremendous work around funding and cost improvement plans. I think these remain a significant risk for us, both in terms of understanding the scale of them this year, but also putting in place the infrastructure to deliver not just non-recurrent cost improvement plans in the first 6 months of the year, but also in the second half. And there's also a moving picture in terms of quite what the scale of our CIP looks like over the course of the next 12 months. But I wonder, Azra, if you could just give us 1 or 2 quick headlines on what it looks like we're going to have to do in terms of SIP this year, recognising there's a lot more you could say, but just 1 or 2 lines now.
Okay, so I think the key thing is just to remind everybody, we entered the pandemic era with a £13.5 million recurrent SIP position. We haven't in reality really done anything in regards to SIPs during the period of the pandemic because we were focusing on other elements. And as a result, we still have that underlying position Plus, we've had additional cost pressures come through, which we haven't quite rounded out because we haven't done the budget setting piece of work yet. But I would expect that to go up by about £2 to £3 million in terms of additional cost pressures that we will see this year, all of which will need to be redressed recurrently. So I absolutely believe this retains the same risk rating that it's been carrying for a period of time. And to contextualise that, we've had non-recurrent offsets against that for a number of years, but that only lasts as long as we have cash available to do those recurrent offsets. So we're probably, if we did nothing, would be okay for about 3 to 4 years, at which point we would fall off the end of a cliff. And therefore, that is why this risk rating retains the rating that it's currently got, and I think it's still appropriate. I'll come on as we go into some of the later areas about the ICS and some of those other risks, but I can see Amlin's put his hand up, so I assume that in regards to this risk.
It is, thanks, Azra. I mean, I guess just very conscious that clearly this has been on the BAF for over 6.5 years as a risk. What it's not easy to tell, I guess, from the papers, because we started kind of plotting how individual risks vary from the beginning of this month, is how it's changed over those 6.5 years. And if it's always been red or significant or 16 and thereabouts, I guess my question is the target risk rating a realistic one, do you think?
So I think what this is trying to do in regards to overarching features is to say we need to get into a position where we are able to recurrently have our costs covered by income. And it's been a building risk. So if you were to have looked at the quantum 6.5 years ago, I wasn't here, but I know it's broadly how that recurrent SIP is brought up. That's been building up over a period of time, probably by £2 or £3 million, with a real increase effectively happening in 2017-18, when we started to see pay awards come back through the system. And what this is really indicating is that the uplifts that we get every year are not sufficient to cover our pay awards that we have for our members of staff. Now, I've raised that pre-pandemic in that planning round, haven't really done it since then, but we have got an underlying issue that we have to address, both in terms of funding, but I think that would be a more longer term period, and then actually looking at how we're currently able to cover that off. So I think it is true that it's been there for a long time. It's been adjusted and modified, I would say, on a fairly regular basis in terms of both risk wording and mitigations, and it has been a building theme.
I mean, I mean, this is one of those interesting ones where it's both an issue and a risk, isn't it? It's a live issue for us, but also the change in financial context means that it's a risk. There is, in theory, an opportunity through the new ICS framework for the ICS and the CCG, such as it is now, to decide to fund us at such a level that we could start to close that gap. Because what we've seen is a 6-year picture of our income going like that, but our cost base going like that. And the income hasn't kept pace. And I think this is where the public narrative is sometimes difficult. It's not cuts to the NHS. It's a cost increase that outpaces increases in our income. You're well aware of this. And I suppose in terms of our goal as a board and our goal as a partner in the ICS is to try to get a fair funding settlement that refers the historic underfunding of Oxleas and some of its funding streams, and one that brings in new initiatives like the MIS and that closes it. So our target should certainly be to close it. We're the only trust in South East London with a 1 rating from NHSI. We're the only one still that's been managing to balance our budgets. So I think our goal should remain to try to mitigate this through effective cost improvement programmes, etc. But it's very difficult, and if anything, I would see this probably moving into a higher risk rather than a lower one based on the conversations we're having within the ICS. The ICS as a whole has an in-year deficit position which is pretty close to Oxley's entire annual budget. And in the context of that, where we've got both Kings and Guys running £130 million or thereabouts deficit positions in year, you know, the notion that we're going to be funded more generously moving forward, I think, is not realistic. So I think this is right. I think it is under a lot of scrutiny. There might be an argument to take it off and refresh it, but I think Azra and our team keep well on top of it. So
I certainly think there's an argument for reshaping and rewording it every single year, just in the context of the budget setting round, which I'm more than happy to do. Steve.
Steve, yeah.
Yeah, thanks, Astra. Just as a general comment on that, you'll see on page 12 where we started to introduce data on the longevity of risks. And there's two that do stand out. This one on cost improvements and 1213 on vacancies, which have both been running since 2014. However, as Azra and Matthew have both said, although the themes and headings are on there over that period of 7 years, the risks have both those two risks have changed tremendously, both in terms of scale and the nature and the mitigations. We have been reviewing this, and in fact, it was discussed at the last audit and risk in March. But part of me thinks we should leave it as it is. Part of it, I do sympathise with Matthew's position about whether we should change it on a year-by-year basis, because it is different. So I think we should reflect on that. But fundamentally, what I'm saying is, for both those two, they're not the same risks that they were 7 years ago. So, but to make it perhaps more transparent, we might want to have a different risk for them both every year, and just say it's only been on there for a year. So I think we should talk about that outside. Yeah.
So I suppose the way I hold it in my head is the issue is we are not funded appropriately for the level of demand we face and the cost of running our business. The risk is that the new financial settlement for this year will leave us with an unattainable cost improvement programme, and that we don't do enough within reasonable bounds to try to save that money. So there's two things there, really. Is that okay, Alan?
Yes, I think that's right. I think the more general point is, I guess, the realisticness of the targets and when that can be achieved by. You know, when you look at the BAF, you see a lot of BAFs a lot of risks that have a target risk rating of low to have been achieved by the end of March, for example. And you just think, actually, to what extent do we analyse whether we do achieve that target historically in timeframes?
So to my mind for this one, I could see a set of circumstances where we actually did reduce this to moderate in the context of what became the in-year risk around the CIP.
Yeah.
So what that might mean is, it might mean that we confront a position where we recognise actually our year-end position next year will be a £5 million deficit, which would be unfortunate, but it would be probably consistent with the overall direction of the ICS and trust individual positions. In order for us to achieve, say, a positive £5 million deficit, we might have to achieve an internal SIP of £5 million. I'm throwing out random numbers here, so don't hold me to these, but illustrative. Say we say to deliver a £5 million deficit for the year, we need to obtain a £5 million SIP. If then in the course of the months 1 to 6, we build up a really good resilient CIP programme that we think by the end of March 2022 would have realised that £5 million recurrent SIP, I would say that the CIP risk for Oxleas would be a moderate risk, because we had confidence in the programme and could see the money coming out month by month. There'd be a broader issue for the trust, which would be our overall funding envelope and deficit, but in the context of a risk attached to the successful delivery or not of a CIP programme, I would feel we've mitigated that appropriately by taking the right steps internally. I hope that doesn't sound too...
No, that's helpful. Thank you, Matthew.
Thank you. Joe.
Thanks. Yeah, just to reiterate a comment I put in the chat, actually. So clearly we are going through some quite significant change in the financial regime, and we did agree at Business Committee a few months back that we would do a wholesale review of the risk register once that had landed. I'm not quite sure it's quite landed yet. So I think we would definitely relook at this risk. I think we would also look at the finance COVID-19 risk that's in there, that we reduced in year. And the other one, which I think is particularly pertinent, is I cannot find it now. It's about the this is collective responsibility for delivery of South East London STP control total. Obviously, STP is now ICS, but I think clearly we are much more in an ICS regime, as Matthew's been and Azra have been talking about. So it won't be at this month's meeting, but over the next couple of months, I think the Business Committee will take a detailed look at those risks and amend, change, close and open based on where we find ourselves and how things are looking going forward.
Azra, did you want to add to that?
Yeah, I just wanted to add in, building on the point that Joe's just made, I do think that the ICS arrangements and exactly how they're going to operate is an emergent risk that we need to keep an eye on this year, wider than just finance, because there is an issue that if somebody dips on quality, one organisation dips sufficiently on quality or in operational performance or finance, it's not just that organisation that then gets put into whatever the new version of special measures is. It's the entire system. So we will absolutely feel it if we're not operating as a system, but we haven't quite landed on exactly how that's going to work, how we're going to monitor those 3 items and what interventions we're going to put ourselves in as a system. And that's part and parcel of what we will develop this year. So I think that will develop over the period of time.
My sense, this is going to become more of a risk for us as an organisation than less, because if you look at the overall ICS financial position, it's pretty grim for South East London, to be quite honest. It's a very challenging position. And what we've got is we're being treated now as a system with a system control total. And yet we're probably, I don't know, somewhere between 2 and 5 years away from operating genuinely as a system in terms of integrated organisations and fully transparent understanding of each other's cost bases, run rates, etc. And there'll be a lot of adjustments in how ICSs work together as well. You know, we've got 3 actually, if you include three large specialist tertiary care providers. And actually lots of their income comes from across the rest of the country as well. And once ICSs start to look at their own funding streams as well, there's a challenge to that cost base. The move away from tariff has affected their profitability as well in terms of some of their cost lines. They are now our problems because we're part of one ICS as well. So you can see where it encourages more shared behaviours, but you know, as we all know, it takes time to build up those right kind of behaviours together to address those kinds of things. So I think this will be a very live risk and issue for the board and for all the organisations in South East London for the next couple of years. Suzanne.
I don't know whether this is the right place to raise this, because I think we're going through the risks one by one, and mine was perhaps a more general point about how risks get elevated onto the BAF. But I picked it up here because the Infrastructure Committee identified a risk back in June 2020 of the likelihood of the introduction of control totals within the ICS impacting our capital expenditure plans. And that never made it onto the board assurance framework because of whatever sort of gatekeeping provision applies. And I think that there is a sort of question here for me about process, because actually I think that had that risk that we'd identified in Infrastructure Committee been viewed as a board risk, the mitigations would have come forward much earlier and would have been much more robust. I think we were caught a little bit on the back foot this year, and I'm very appreciative of all the work that ASRA did in order to put us in as good a position as we could be. But it did feel very much that we were sort of running to catch up with a risk that we'd sort of identified earlier but hadn't quite identified the gravity of.
Yeah.
Can I just come in on that? So I think it was because when we looked at that, I think I treated it as an in-year risk. And I do think that is something that we need to think through as a board about exactly how we go through it. Because the settlement that we got for 2021 effectively gave us everything that we wanted and did not actually adversely impact on our capital programme, that was why the risk went from the initial identification down the way. But that only related to 2021. I think you're absolutely correct. What that was a precursor of what future risks were going to look like in future years. And I think that's the element that we probably need to draw out a little bit stronger, is as we go through this ICS, it's developing in future forecasting and maybe looking a bit more at the emergent risks. So I absolutely think that was an emergent risk, but didn't make it onto the BAF. But I don't think it was a 2021 risk. It clearly is a risk coming into this year.
Okay, Andy, are you happy if I push on?
Yes, please, Matthew.
Okay, so I think for the next couple, we've got vacancies and recruitment pressures, discrimination at work, and staff satisfaction and retention. I'm going to ask Rachel Clare just to say a couple of words on these points.
Thanks, Matthew. So I'll try and be brief, but very happy to answer questions. So risk 1213 is about our inability to recruit all the staff we need, and This is pretty much a constant, I think, for NHS trusts, and has been, as people have already noted, has been on our risk register for a long time. So we did have a discussion at both Audit Committee and Workforce Committee as to whether or not this should become a tolerated risk, and we decided that it shouldn't. We felt that the context regularly changed, the interventions were changing, and that it needed our sustained attention and focus. So the approach that we take is to try and make sure that our recruitment processes are as efficient as they can be and that our time to hire is as quick as it can be. We try and make sure that we're creative in our approach to getting the right skill sets and working out where we've got a glut of skills and where it is that we need to kind of think a little bit differently about how we design our roles. We try and make sure that we use the right channels to access the applicants that we need. And we're trying to get much more savvy about how we use our rostering, because we know if we're more effective at rostering, we're able to get the right interventions in place in time, we're able to get the right bank staff and are able to rely less heavily on agency staff. But this is an area that we keep under regular review, and we try and keep fresh our thinking about these things. So, for example, we have just created a new recruitment hotspot role that will help us with those hard to fill areas, particularly, for example, in relation to prisons expansion. We want to get much more assertive in our approach to workforce planning, and we're working closely with clinicians, the clinical leads, about how we do that. But we do know that the best way of attracting and keeping staff is for Oxleas to be known as a really good place to work, and that's why making Oxleas a great place to work is such a central strand to our strategy. And there are so many elements that kind of build up. And it's how we capture the imagination, I think, of local workers so that they want to come and work for Oxleas, and things, even small things like the pick-me-up boxes, can make quite a difference in that context. Sue raised a really important point that when we bring that when we bring agency staff, we need to be really careful that they are properly inducted, and Jane has been talking about how we make sure that when agency staff come into a new environment, we do spend time making sure that they are inducted, are given the right information beforehand, because we do know that that's a really important part of getting the quality of care right. The point that Amlan raises about what we're actually aiming for has made me kind of think whether or not we've got it right actually in terms of our destination, in terms of what we're aiming for. I suspect low is probably ambitious for us in relation to this risk, and that perhaps moderate might be the right level. But we're due to have a wholesale review of all of these risks at the forthcoming Workforce Committee, so perhaps I could wait until we have that discussion before making a firm decision on that one. Any questions or comments on that one?
Stephen's hand's up there.
Yeah, thanks, Matthew. Thanks, Rachel. And I agree with you. Well, certainly it stays in the remit of Nina and the Workforce Committee. And I also think Matthew touched on it at some date. You'll probably end up with this as a tolerated risk because it's just a regular ongoing issue. But the only thing I would add to it, and the mitigations, by the way, I think are really good, as Rachel has just outlined. But the only major caveat I would throw into this is when you look at the NHS 5-year plan and the additional funding and the additional staff, which is all in the plan that we need to obtain, and we do across the whole of the sector. You know, you're going to have a pool of labour which is probably not increasing very much, and much more competition to get those staff. So I think getting it down to low will be incredibly challenging. And if anything, I think that is going to become a more significant risk over the next couple of years. So it's not probably now in 21, but you know, moving into 22, 23, because you know, there'll be a lot of organisations competing for a limited number of staff until, as a sector, we get fully trained up staff coming through, which we know will take 3, 4, 5 years or something of that nature. But you know, hopefully at one stage we'll get it to tolerated, but I personally don't think we'll ever see that as a low risk. That's it.
Thanks, Stephen. Rachel, next.
So shall I move on to the next one? I agree with all of that, Steve. I think you're absolutely right. I think we need to think very creatively, particularly about how we use the third sector to help with some of those people plan deliveries as well. But you're right, it's not going away anytime soon. Matthew, shall I move on to the next risk? Thank you. So the next one is 1471. It's about the risk of staff experiencing discrimination, violence and aggression at work. And this is something we take extremely seriously in Oxleas and that we have really been reflecting on over the last year. So our whole Building a Fairer Oxleas programme recognises the substantial challenges that we have in this space and the huge amount of sustained commitment we need in order to be making a difference in this area. There's a lot happening, but it's still really pretty much in its infancy, and we'll only start to really move the tanker, I think, if we keep going and really put our backs into it. When it comes to violence and aggression, we've seen some really promising results, actually, when it comes to our quality improvement programmes. Christine Kapopo has been involved in work that's led to some really substantial improvements on some of our wards. We're also developing some really great partnerships with the police, particularly around Operation Cavell, where they're committed to making sure that abuse, hate crime, violence against NHS staff is taken as seriously as it is against the police, and we're starting to see real improvements in that area. We also know that when it comes to bullying and harassment, that our values that have kindness and caring and fairness at their core will be part of how we go about tackling that bullying and harassment work. But these are really big issues to try and tackle, and we've got big programmes of work to support them, but they will need sustained commitment from all of us, I think, to make the changes that we want.
Okay, can't see any hands, so I think next one, Rachel.
Thank you. So that's 1502, and that's about staff burnout. And I think this is one that we really need to keep a really close eye on. We need to see how our staff are going to be responding in these months as we start to emerge from the pandemic. Will we see people gradually returning to normal, or are we going to start to see increased sickness levels, stress levels, turnover or retirement? We're not seeing a huge amount of that at the moment, but it's really early days. We do recognise we may need targeted interventions for particular groups. We're hoping that Schwartz rounds are going to help in terms of giving some people some time to reflect and to recharge. But this is something that we're going to really need to keep a close eye on, I think, over the coming months.
Thanks, Rachel. Okay, if no questions on that then. The next one, 1565, is collective responsibility of the STP control total. We need to change that to ICS control total. I mean, I don't think there's any more to add on that, really, beyond what we've said, other than it's now all of our problem. So unless, Stephen?
Yeah, Matthew, as Joe's already said, business will be looking at it because it has changed substantially. I do think for infrastructure as well needs to look at it from the capital perspective, not only because I think it's bordering on a significant issue, this, on the capital side of things. As Azra said, probably not for the immediate year, but for next year, partly because of the potential difficulty in us being able to spend the capital as we would wish, and that has an enormous impact across the organisation and our service users, but it touches on the sovereignty of us as a foundation trust. So infrastructure doesn't have any significant risks at the moment, and at the next meeting it would be very good for us to reflect on that capital, on a new risk to sit in there, and it should be, I think, in the board assurance framework. So probably have one for infrastructure and the one that Joe mentioned, a rephrasing from business.
I mean, I think all the financial risks will be different next, because we haven't finished the annual planning process yet. So I think what we're looking at the minute is as a set of financial risks that will be different by the next time we meet as a board. Azra, do you want to add anything?
So I was just going to add, I think also the risk rating is likely to increase on this one once it's been rephrased, just given the direction of travel and how this year's planning round is looking.
Agreed, Azra. I think that'll apply to all the financial ones that come up here, I think. Okay, next up we got bed management and financial pressures. I'll ask Ian to come in on the bed side. I just think for a bit of context, I had a look at where we were at the end of last year, just look at our bed usage and comparing our adult bed usage excluding PICU. In March 2020, so just before the pandemic had kicked in, we used 4,400 occupied bed days. That was our inpatient bed base plus our UEA, so 4,400. March 2021, we've used 3,500. So there's been a 20% reduction in our bed usage in March year on year, including UEAs. Our year-end position last March was 54,700 bed days. Our year-end position for March just gone was 41,000, so we've reduced our use of inpatient bed days for adults in Oxleas, excluding PICU, by 25% over the year. So in the context of the ongoing position we do have around UEAs, I think it is worth bearing in mind that we've reduced by a quarter our use of inpatient beds for adults, excluding PICU, over the course of the year. I know the pandemic's really changed that position, but the in-month position for March, where the external demand has remained on a par, if not higher than last year, that 20% reduction is significant. And I have to say, if Ian and the team had set a goal of a 20% reduction in bed days, I think we'd have said, no, that's too ambitious. Let's aim for 5 to 10. So I think in the context of the ongoing bed pressures, it's just worth recognising that is an achievement I would not have said I thought was a sensible one to put in as a goal for an organisation, actually. You know, when you see these kinds of things, they're usually framed in the 5 to 10% kind of realm. So we have had some really big impacts there. That's not to say it doesn't remain a really significant challenge for us, and people are undoubtedly still waiting too long in different parts of the system. But I think I'll just go to Ian in a minute. Steve, your hand's up.
Thanks. I suppose my immediate response to what you've just said, Matthew, is it all depends what's going on. What's driving that? Because it could be people just aren't accessing things at the minute. And if you look at the I'm sorry, I'm jumping in front of Ian, but you look at the mitigation, a lot of that depends upon community-based services doing a lot more than they currently do. I think just given the pressures they're under now, never mind the pressures they would be under if we further reduced our beds. I worry about that being the tools that we will use to do it. I also worry very slightly about sometimes it's right for someone to be in an inpatient situation. So we just need to be really careful that we're not saying all inpatient stuff or giving the impression of that. So we worry about that. And the last thing about the thing that's driving it is my interpretation of some of this is we always use slightly more than we've got, and it almost doesn't matter. So there's some behaviour going on here, which will say almost irrespective, within reason, of the number of beds, the Oxleas beds we've got, we will always use slightly more than that. And the other bit we have to worry about is us reducing our usage, just pushing the pressure somewhere else. Because I do think that some of our partners, I know some of our partners are feeling some of the heat on some of the things that we're doing. So we just need to be aware of that as well.
I mean, I think we know that emergency demand, certainly, in March this year, it's been higher than it was last March. So in the face of increased demand through emergency, through ED and also through home treatment team referrals and others, and we're certainly making less use of inpatient admission as part of people's care pathways than we were a year ago. The year-on-year figures are difficult to look at in terms of the whole year because the pandemic's really changed that. I do agree with you. I think, Steve, if we had another 40 or 60 beds open at the minute, we'd be running 3 extra wards, and we'd still have UEAs on top, I think, until we get some of those practice changes through. And that's partly what's driving the change to have a service director for acute and crisis care supported by their clinical teams to look at this and how we manage this day in, day out, and how we manage the practice around that while we're developing the community support around it as well. But I just think it's worth noting that whenever we think about this and we think about the weights, we are operating on a significantly smaller bed base. We're also in a context where if we did want to say reopen 2 wards, it would be entirely bank and locum staffed at the minute. There isn't a workforce out there for us to do this as well. So all these things are entwined together. And it's a long, slow, daily job of doing the same thing every single day and trying to do it slightly better, which is the real grind in this as well. But, I think it's worth recognising that I think our clinical teams and operational teams have achieved a lot in the course of the last 12 years, the last 12 months in some really quite tough circumstances. And we'll go over to Ian, please.
Yeah, thanks, Matthew. I mean, some of what I was going to say has already been covered, but I think that context of how activity has changed over the last year is helpful. One of the things that's already been alluded to is it did enable us to close 2 wards. But as I think Steve's highlighted, we still have a kind of residual gap between the activity or the demand and the beds that we have, and that does mean that we continue to need to buy capacity from the Priory, but also on occasion use other private beds as well. I mean, I think the point that Matthew's made about even if we wanted to open the 2 wards that we closed, I think it would be really, really difficult. It would be difficult anyway in terms of the workforce challenges that Rachel's already mentioned, but we also know that we've got to grow that capacity in the community. So we can't have a situation where we are kind of spreading the recruitment that we are doing too thinly. I do think there is a conversation, however, to be had around the proportion of beds that we have for adults as opposed to older peoples, because for all the time that I've certainly been in Oxleas, so that's, you know, getting on, that's over a decade now, our older people's mental health bed usage has always been way below what's been commissioned, and adults has been higher. So is there an opportunity to kind of reset some of those beds? The other thing I was just going to mention in terms of kind of controls, I think Matthew's highlighted that you know, when we've talked about this over the last year, we've wondered whether the pandemic has driven a change in the way that people are accessing services. But I think since February this year, demand has come back to the same level it was pre-pandemic. We certainly got much better controls in place. We've now got 3 times a day bed meetings, which I chair or a deputy chair. We're much better sighted on the capacity that we have got. We're much better sighted on the pressures that Waits can have on partner organisations, which again I think is something that Steve alluded to. So there is now a daily report across London around the numbers of people that are waiting in EDs over 12 hours, and we're able to kind of see how we compare against other trusts. And we have regular communication between ourselves and acute providers to try and minimise that. But as Matthew says, it doesn't mean that they don't happen on occasions. Yeah, I think the controls are in place. The other thing I just wanted, a couple of other things just to mention. I think Sue asked around this concept of purposeful admission. Just to come back to what something that Steve asked. This isn't about keeping people out of hospital who need to be in hospital. It's just being thoughtful and working with them on whether coming into hospital is the right thing to do. And of course, alongside the daily work to manage flow, there is the developmental work that we want to do over the next few months, which are around growing the crisis offer. And that is something that we're actively taking forward with the third sector, looking at ways to help people to leave hospital when kind of discharge is being blocked. Again, something we've got a few initiatives going on with the third sector. And then the last point, which moves on to the next risk actually, is around really getting on top of the activity in the community and making sure that those teams are set up to meet people's needs in a much more effective way than perhaps they are now in some cases, and that does lead to admission. So yeah, I'll stop now.
Thanks, Ian. Yemisi.
Thanks, Matthew. Ian, I just wanted to ask, the controls that you've talked about in the community to support the reduced bed base, how sustainable are they in the medium to long term? Because, like, for example, you're chairing bed meetings 3 times a day. That's not really sustainable. And are these kind of controls very short term, and you're looking to other controls medium to long term, or what was the general thinking?
So I think you're right to highlight it. It probably isn't sustainable. Matthew's talked about the structural changes we want to make in terms of the how the service directorates are structured. I think creating an acute and crisis service line will enable some of those controls to sit further down the organisation. And for the buck to stop with the kind of one direct service director and clinical director in place. So that will hopefully kick in September. So it's really just about, from my point of view, I think it's worth my time investing in this in the meantime. Some of this is about spotting opportunities to do things more efficiently, and that's part of what I can spot and bring in other people to help. But some of this is about affecting cultural change, and I think there is something about me being seen to lead it and having conversations directly with the likes of matrons, ward managers and others to help them to see how they're kind of part of a much bigger context, and the fact that their actions do have an impact on the way that people, or the time that people wait in ED, is quite important. So I think the kind of short answer is it's short term in terms of me, but I think the structures we're putting in place will need to continue forever, basically, but within the context of a new service line.
I mean, I think it's a good point. I mean, the service director's job in acute and crisis, at the minute, the first post in the organisation where the bed base and everything and the community stuff comes together is Ian. And that is an unsustainable position. And that's been one of the big drivers for the proposals around the structure changes. When we've got a service director, clinical director, head of nursing, head of therapies, etc., working around the acute and crisis model, that will be the place we look to. And we're going to have the community mental health service director looking at the community dimension, and that's the next point on here. I'll maybe look to Iffy or Abby just to say a bit about CMHTs as well, because I think this is a really integral part of how we manage the bed use, because the bed use is only ever a representation, I think, of what's happening in the broader community. So I don't know, Iffy, if you or Abby wanted to just say a few words about CMHTs.
I think Abby is best placed for that. She's driving that in Greenwich.
Nicely done, Iffy. Abby?
Yes, thank you, Matthew. This CMHT work is happening in the context of the long-term plan and the trust strategic plan. And as Ian alluded to, we need to be able to equip our CMHTs to actually provide the care that they're supposed to provide, which at the moment is a bit challenging for them. And that would include working a lot more with primary care, but also looking at the skill mix within the teams. I think one thing that has historically happened with CMHTs over the last 10 years is that they've been seen as a place which is a catch-all. So whatever patient doesn't fit into one of the other kind of specialist teams ends up being with CMHT, and human beings don't fit neatly into boxes. So we've got to look at what else is available, which will include working with primary care, working with the third sector organisations, looking at the skill mix of the staff we have, and looking at the skills that we need to equip them with in order to move things forward over the next 5 to 10 years. I'm happy to take any specific questions, but that's just a broad overview.
Thank you, Abby. Any questions on that one? That's the CMHTs. I mean, we'll come back to that repeatedly over the course of the year. Yeah, Missy.
Thanks, Matthew. Abby, you were talking about CMHT having to work with primary care. How confident are you that we can build those relationships sufficiently for that level of work to be successful, to take the pressure off that team?
I am confident that we will get there, but we will get there at different stages in our different boroughs. That work has started in Bromley probably 2 or 3 years ago, and there is something about relationships and engagement. I think COVID has placed extra pressure on primary care, so whatever we do with them has to be seen as supporting rather than adding to their workload. So what they've asked for on numerous occasions is sort of having a named person or knowing who the go-to person is for their practice or their area, and that's already been developed for this year. So each primary care network is supposed to have a mental health practitioner who will support them in addressing some of these. So it will take a while, but I am confident that we've got the right idea at the moment to help with primary care and sort of stepping people or making sure that there's a fluid arrangement between primary and secondary care.
I've got Suzanne.
It's just a very brief point about the dates that were put on here for the target risk rating to be achieved. So for both of the 2 risks that we just talked about, which are very long-term pieces of work, the target rating was supposed to have been achieved by March this year. So are we being a little bit unrealistic when we create these initial risks in estimating how long it's going to take us to get serious mitigations in place?
I think that's a fair challenge, Suzanne. Ian?
Yeah, no, it's absolutely a fair challenge. I mean, the beds risk has been around since 2017, and I think it's probably predates that. So I think, yeah, we do need to do something about that. I think in terms of the community, I think the pandemic has probably had, no doubt has had an impact on us driving some of the transformation work that we needed to do in the community. But at the same time, it's probably created some opportunities, but also some risks, because it's enabled us to look at our operating model and how we deliver that service. And we know that we are actually meeting some of our service users' needs probably far better through things like the use of technology, and it's helped access, and it's actually helped our staff in terms of their time and capacity. But for other people, it's not been so good, and that has kind of played out in a rise in admissions for some groups. So I think it needs to be considered in the longer term. That changing context needs to be taken into account. But I think the other kind of positive enabler is that we have got some investment coming in. As we've already heard, that the workforce isn't necessarily there. But I think through through discussions and partnership work, certainly with the third sector, but also GPs and the PCNs, and there will be explicit roles for kind of link posts between primary care and secondary care. I do think we're probably in the best place we've been for quite a while. But yeah, I think we're talking a kind of 2-year programme, probably at least.
Okay, thanks, Ian. And I think the general comment about realistic goals and timeframes, we'll take that to a review via the exec, both for the outcomes we want. I mean, bearing in mind the financial ones are going to change as well, but also the timescales to make sure that they are realistic. Next up, we've got finance COVID-19 risk, which I think is probably best seen as part of the overall pot of risks that we're trying to address around the money. I mean, as a general point around COVID, I think it's probably worth noting, I mean, we've got it further on in staffing levels and staffing pressures, that we need to just think about how we reflect that risk going forward. You know, at the minute, it's not an issue in terms of staff sickness, it's not an issue in terms of inpatients and so on. So I think all the COVID associated risks need a bit of recasting as well as we think about what the next wave might look like later in the summer. Azra.
Yeah, and just to say specifically on this one, from the COVID pot that we were allocated, 5.6 million for H2 of last year, we underspent that by £1 million, and that was with even the very significant impact we saw with the peak that we had in Q4. So I think that this will be low risk. I think the bigger element is the impact of COVID and what that's done to waiting lists, but the funding does not cover that specific item. So I think there's something that we probably need to do in terms of reframing impact of COVID versus actual COVID, because I think the sickness, even if we had something in summer, because we've got the same replication of a COVID pot for H1 of this year, will more than cover what we are requiring for that.
Thanks, Azra. Okay. So next up, we've got CMHTs, finance COVID risks, we've got prone restraint, and I was going to open this by maybe suggesting, I know there's a lot of interest in restraint as a general topic, and I wonder if it's worth us doing a sort of specific session on restraint in all its forms with the Council of Governors and NEDs at some point in the next couple of months, and perhaps to bring some of our clinical staff voices into this as well, because there's a real range of different opinions on how we frame some of these goals and how we frame it in practice. And it's been interesting actually taking this through some of the shadow exec discussions. And that is a group made up predominantly of staff who are working day to day in clinical and operational frontline roles. And they have some quite different perspectives on some of the language we use around the goals in this based on their experience of abuse and risk of violence within the ward environment. So I think it'd be worth us trying to reflect some of that richness with the governors and the board at some point in the next couple of months. And Jane, I don't know if you want to just summarise for us some of the controls we've got in place around this, some of the activity.
Thank you. I certainly welcome that suggestion, and Matthew, I think it would be really valuable. Just to reiterate, we are determined to stop restraints, but we do recognise that in exceptional circumstances they may need to be used, and obviously when they are, the preference is for supine as it's safer. But where we can't not use it, we insist that it is timed, and for prone restraints there are desktop reviews that are carried out and signed off by the service directors. Our focus has really been on improvement, so this is building on the QI work around reducing violence and aggression, so using things like the Brosset tool and the Keep Me Safe and sustaining those areas. We've been looking at where the key hotspots are, and we recognise this is around our psychiatric intensive care unit. It's hotter and the patients are a very different group. So we're very much supporting that team in looking at ways to try and reduce restraints there. There's been deep dives, desktop reviews, and there's a group of senior managers working with the staff to look at it. Some of the things that they're putting in place is making sure that there's consistent presence of senior leadership at all times. There's really good support with care planning, proactive use of rapid tranquilization. And they're also going to be rolling out some relational security training that we've piloted across other parts of the trust, and review their staffing and bed base as well. We've been working very closely with an initiative across other London trusts, looking at relational security, rolling out the See-Think Act framework in Woodlands and on Avery Ward and Goddington Ward. And this is a very interactive full team workshop with workbooks, reflection and tools to establish mutual expectation agreements with service users, including those who are admitted informally. And feedback from the Bexley teams particularly, not to say that the other teams aren't flying as well, is that they really appreciate it, and it's making a really big difference to how they're approaching this as a whole team, and they're seeing some very clear reductions in the numbers of restraints and the violence aggression that they're experiencing. In June, Goddington Ward are going to be the first ward to roll out the safety pod. The standard operating procedures completed, they've been trained, we're just finalising refresh in deltoid injection techniques, and then we'll be rolling that out to hopefully the Bexley and Greenwich wards around August, and to Atlas and the health-based place of safety later in the year. There's been a lot of investment in leadership support. Our ward managers in the working age adult wards have undertaken action learning sets over the last 6 months to really support them with their leadership and to give each other support so that they can, really helpfully supervise people and make sure that they are supporting their team and getting the support they need to drive these agendas forward. We've been focusing on physical health monitoring after rapid tranquilization and visiting of the wards and providing training that's on videos and making sure that they've got handheld devices to do this. And we've got informatics producing reports of any restraints which come out weekly and go to the service directors and clinical teams so that they can specifically follow them up. All of the body-worn cameras have been replaced on the working age adult wards, and I know Heath are also looking at these. And I know that Rachel's also briefly mentioned Operation Cavell with the Metropolitan Police, and a similar model has been in place in forensic for a number of years, has been well received. But I think most importantly, we've got a really committed, highly experienced, proactive leadership team taking this agenda forward. So the named lead is my deputy, Christine Kapopo, and we have a matron, Naidu, who's linking in with the Cavendish Square group, taking the learning across London and sharing that. And likewise, we have Chris Nakin, a head of nursing, who's linking in with the South London Partnership. So we are absolutely committed to making as much improvement and supporting people with the cultural shift and giving them the tools to do this. And I think things like the safety pods, for example, we are expecting to have significant results. So we'll be evaluating and reviewing the risk rating as we get towards September.
Thanks, Jane. I mean, it's a really comprehensive programme, and I think it'd be good to bring it for that fuller discussion. Amlan.
Hi, thank you for going through that, Jane. Apologies if I've missed this, and I should probably know the answer to my question, but what methodology do we use for restraint across the business? Is it PMVA, is it MABO, or does it differ?
It's PMVA, and we use PMOVA as our trainers. And Pamova, we're buying them a couple of safety pods so they can get training with our staff on that as well.
Right, because I think often there is something about the training aspect of restraint that right at the beginning, if the message is kind of, through that induction process about alternatives to prone, that's also very helpful from a methodology perspective. The second question I had was just about how we compare to other NHS trusts on the use of prone. Do we have any data on that?
There is national benchmarking. I haven't seen the most recent one. I can check it for you and circulate it, because I think the data that we have is slightly dated at the moment, but we're not a significant outlier from my memory.
Okay, that would be really helpful to have a look at, I think, because there's no surprise that I guess the hotspots are generally the PQs for prone restraint, and doing a bit of occupied bed days analysis benchmarking on the PQ front between us and other trusts might be helpful. Thanks, Jane.
Okay, Steve James.
Thanks, Jane, for that. That was a very comprehensive list of things that we are doing. I have a slight nagging doubt in my head around the sort of culture, hearts and minds bit, because I'm not sure we have managed to communicate what I'm sure people feel, which is prone restraint should be a really exceptional thing. I mean, we should have a position where we don't think we should use it at all. And on the very, very rare occasions it happens, there are, I don't mean consequences to the staff, but there's a significant organisational response to it, because it's really, on all sorts of levels, it's really not a good thing. So I wonder whether or not that training is really key to that, whether or not all of those initiatives that we've got are sort of bound together by that sort of cultural thing that says, actually, we really, a lot of organisations, we don't use it virtually at all, if ever, and that I'm not sure we're there yet, and the figures suggest that we're not there yet, because despite all of that stuff, if we're being charitable, it's not shifting. Some months it goes up. So have we cracked the hearts and minds bit about the culture of this organisation? Is it doesn't prone restrain people, because you can talk to clinicians, I have, who will say you need to.
Yeah.
And I just think there's a thing about, if you start from a position of we need to do this, then you'll do it.
Can I come in?
Mm.
So I think you're right to some degree, Steve, that there's still some work to be done with respect to hearts and minds. But what I've always said about this is that we're very clear in our minds that as an organization, we want to stop prone restraints, but we cannot say it should never be used, because there are times when clinicians just have to use it. And this is why, as Jane has said, we ensure that whenever it is used, that we review what has happened and try and learn lessons, which means, why did it happen? What could we do differently the next time? And we make sure that the staff are aware of them. And some of the reviews that I've looked at have been that detailed. I think the other point that Jane has made is that we have now narrowed it right down to an area where it seems to occur more or commonly compared to other parts in the trust. And in fact, on Friday, I'm having a meeting with that team to talk about this particular issue of our culture. I think we still have some staff who would prefer to use prone restraint, particularly if they also need to administer medication to calm the individual down, etc. It's safer, because then you don't end up with needle stick injuries either to staff or anyone else. But this is work that we're constantly keeping an eye on. And your point about, at best, we haven't shifted. You've got to remember that the way we capture the data is about the number of restraints, and sometimes one patient could generate quite a few, and that makes it difficult. And we've been absolutely transparent in looking at the incidents as opposed to how many, as opposed to the people, and so it's likely to fluctuate. it really is likely to fluctuate. And at the risk of wanting to do further in-depth work, looking at the data, if we have to, we may have to say how many individuals are involved. Lastly, I do recall that in one of our PQACs, Yemisi as the chair raised a question about the length, the duration of the prone restraint. And when we went back, it was the same patient who was constantly breaking loose from the staff. And so it gave the impression, as though when you look at it on paper, as though that one patient had been held down for, I think it was something like 10 minutes, when in fact it wasn't 10 minutes. But again, for staff who are involved in this, being able to capture the time can be quite difficult. It's not as though there's someone standing there beside them with a stopwatch, so people kind of guess how long that may have taken. But just to again assure the board, the message is definitely loud and clear. In the acute care forum that I chair, every mother matron brings to that forum every month what prone restraints they've had, what lessons they've learned, what they've done differently, and I am keeping a very close eye on this in terms of working with the frontline clinicians in the teams to ensure that we drive this agenda forward.
Thanks, Ife. I mean, I think there's certainly the level of interest in this, I think, would warrant that fuller session. And I think, to also bring some of those staff stories through would be really helpful to understand the context people are working in, and also some of the nuances of reporting as well. Some of the prone restraints are very much transitional on way to different kinds of restraint, and the timing factor is a really important one. I think, you can't help but think of some very prolonged, disturbing stuff that we've seen over the course of the last year around the use of restraint and so on. And I think to get some people to talk through the context of some of the things of how this is used, Iffy's example just then, would be really helpful. Amlan.
Just going back to the issue of restraint methodology, I'm conscious that in some PQs I'm familiar with, we've changed the restraint methodology from PMVA based to MABO, which has its kind of origins in learning disability services, which actually doesn't allow the use of prone restraint as a technique altogether. So even when administering rapid tranquilization, there are ways of being able to administer that without necessarily having to use prone. I'm afraid that's where my level of expertise ends, but I mean that's what I have heard, and I think it's just worth exploring, even if that isn't word for word correct, but worth having a look at. The other point was just to lead on from Steve's kind of view about the tone of the conversation. It reminds me a little bit of the conversations that I've had with clinicians around the whole idea of zero suicide as a concept. And of course, you will have clinicians that say that that's ridiculous, that suicide is a known tragic outcome of serious mental health issues, and having such a target is unhelpful. But I think that kind of misses the point, that it is an aspirational target that we should be reaching for. And zero prone restraints kind of I see as a similar kind of tonal message from the organisation. So it's just something to be conscious of. I think, if we were to think of it in the same way, we might think differently about bringing it to a committee where it's discussed kind of, there's a narrative attached to it, and then that happens on a frequent basis. So we might just consider that in terms of the messaging.
I'll come back to it, but I mean, there is a significant difference, isn't there, between saying our goal is zero use of prone restraint and saying we banned prone restraint. I think if you say to staff you're not allowed to do something, there's every chance that they'll still do it and they'll just report it differently. And you've got to be very careful about how we frame some of these things, because if there's I was on a ward recently and I was asking them about their prone restraints, and I was asking how's this been going. And I think the staff's initial reaction was as if they were in trouble, because I'd come onto the ward and I'd started asking about a couple of prone restraints. They were worried, and I had to reassure them that I was genuinely interested in the application, the methodology and the training they'd had and stuff. I wasn't there to give them a dressing down for restraining people. And we do have to be very careful about how we frame this in a spirit of encouraging transparency amongst wards about their clinical practice and how they're doing that as well. I mean, the zero suicide one as well, there's things about how that's set as a goal how it's reported. And with a lot of this, you know, we can sit here and have a fairly nuanced discussion about the difference between a goal and an absolute ban on something. It's not always experienced in that way by the people that are working in clinical practice as well. And I think what Jane's described is a full range of measures that are designed to give people the right tools and to create a kind of cultural change around how we approach some of these things. You know, these are long, slow pieces of approach. And what's interesting is the reaction you get from some frontline staff who've been punched and bitten, had broken arms and so on. When you say we'd like you to use less restraint as well, you know, you get into an interesting conversation with them about how they're supported to do their job with some very difficult patient groups as well. And I think we have to, you know, I think that's why we need to hear some of these voices, because, you know, if we're serious about board to ward, let's hear a bit more of the ward voice in this as well, in the context of how we're putting this support around it. So I think that longer session will be worth us doing. Iffy.
So I agree with all of that, Matthew, and thanks for saying that. Just a couple of things to say. So when we first adopted the zero prone restraints approach, we had a lengthy meeting with Pamova about the PMVA training and made sure that they were taking account of our position, and in particular emphasizing supine restraint and the risks that are attached to prone restraint. And I think that that message is very clear, and we've changed our policies, etc., in that regard. The other thing that we perhaps haven't touched on is when you look at all the literature, and in fact, we did quite a bit of work on the TAN many years ago as part of the national NAPICU, that incidents tend to occur when patients are not engaged, and incidents tend to occur more when staff are distracted, perhaps through during the periods of handover. And so there's a lot we need to be doing in Oxleas about making sure that people in hospital are fully engaged through activities organized by staff, be they OT or nurses or non-qualified staff. That's really critical. And the other really important thing is psychological intervention, not just for the patients, but also for teams to understand what's going on here. You know, when I worked on the town, we've successfully managed to reduce restraints through engagement. So in my meeting on Friday, my emphasis is going to be about the need to engage people on the ward. We got to a point where people wanted to come down to the town, not because we were restraining people, or because they felt that they were going to be engaged, listened to, and helped to walk through their difficulties. So that's where I want us to focus our discussions with clinicians, you know, so that when the restraint occurs, it's about how come that occurred. Does that mean that the things that should be happening, you know, have failed? Rather than saying we shouldn't be doing using prone restraint. I hope I'm making my point clear. You know, it's about really understanding the needs of people, preempting what's going to happen, talking those things over, engaging people, and helping them move through their inpatient stay safely.
Okay, I think that's all the hands for now. We certainly do, I think, need this session on this, so we'll get something in the diary for that as a matter of urgency. We'll make sure the governors are fully involved in that too. Okay, next up we've got pressure on district nursing teams. Ian, do you just want to give us 1 or 2 lines on that?
Yeah, sure. So colleagues will remember that we raised this as a risk back in the autumn, and that's in acknowledgement that the pandemic had exacerbated existing pressures on the services. It's very clear that the pandemic has increased activity in both Greenwich and Bexley. So in Greenwich, I think the increase has been in referrals has been around about 25%, and in Bexley it's been even higher. We've mitigated that in the short term by use of short-term funds that have been released, kind of badged as COVID pressures, and we've also in both Greenwich and Bexley managed to reroute some activity that was going to district nursing to other places, and we've had the ability to kind of co-opt practice nurses and nurses from what was the CCG. I think in the future, though, although we don't quite know how it's going to be, that demand isn't going to go away for district nursing. they're very much fundamental to the concept of home first. They are fundamental to keeping people well in the community. So this will require targeted investment, and certainly as part of the planning round conversations that Azra and myself and others have been involved in, we have made sure that district nursing is at the kind of front of the queue for any funds that come to adult community services, with a higher proportion needing to be directed to Bexley for the reasons that I've said. So I think in terms of can we then spend that money, I think both district nursing services have got a good story to tell actually in terms of recruitment, and you know, certainly Bexley have got really good levels of retention and recruitment. Obviously we need to keep that under review given the kind of age of the workforce, average age, but I feel positive about that. And I am really advocating for the service directors to ensure that they are kind of raising pressure on district nursing through the individual borough local care partnerships, because some of this is about really taking the conversation to general practice as the kind of main referral source. So that's all I need to say, I think.
Thanks, Ian. Azra.
I was just going to add on, I have to say the settlement for community physical health uplift in comparison to mental health is quite stark. So we actually went with a circa, well, above £10 million ask on the physical health side, and the funding envelope is probably looking at about a fifth of that in terms of funding it out. So it's just to kind of set expectations of the amount of money flowing through to actually address some of these really significant needs. So we've both been very clear about what the ask is and when it's featured on every single conversation, but I don't think there will be money flowing that will allow this and Home First and a variety of others to effectively be invested in this year, although they have said there's a trajectory over the course of the next couple of years. So we may need to adjust the target date, I think, for when we're going to address it to be a bit longer.
Thanks, Azra. And next up, we've got wait times in community services, which I think remain a concern, and it kind of follows on a bit from what Ian said there. I mean, certainly at the Children and Young People's session yesterday, it was really interesting to hear that actually we've made some really good inroads on reducing some of those wait times through their application in that methodology. At the same time, they've also seen recently some very stark increases in referral numbers. And there's a persistent problem in community services where, as Azra said, the funding base isn't necessarily there. The staff are quite hard to find. And what we're actually seeing is that services that were already under commissioned, the demand is actually increasing. So where we're able to eat into the backlog through innovation, etc., we're doing that in the face of increasing demand. So this is going to be a pressing issue for us. And obviously one of our strategic priorities of zero delays is very much attuned to this. Ian.
Yeah, no, thanks, Matthew. The only thing I would add is, I mean, you've raised quite rightly the kind of the neurodevelopmental weights in children and young people. I mean, they are of particular concern, but similarly in adult services as well. And at the ALD operational review earlier this week, we heard about the differences between the three boroughs in terms of their wait times. And what was interesting is that Greenwich is much better, although it's still got a long way to go. And the only reason that has got better is because there has been additional investment which has then enabled us to do more assessments. I think we've really majored on being as productive as possible and looking at all sorts of alternatives, but there is a kind of structural element that you can't get rid of. But I think in the operational report that's later on the agenda and is a feature of every board, I think that allows the board to see how individual directorates are focusing in on their particular hotspots.
Thanks, Ian. Next up, local authority contracts for integrated and embedded services, and this is about historic funding, and I think we're aware of things like the Bexley withdrawing their money from CAMS and others, and this is a real pressure, I think, and thinking about the ICS position, but also these important partners. Ian.
Yeah, I mean, my feeling is that it needs to be on here as a risk for for the time being. I think how things have played out this year hasn't gone quite as we anticipated in a positive way. So I think in terms of adult social care, we have seen a reduction of money being taken out of secondary care social work in Bexley, but that hasn't been lost to the system. That has been negotiated with us, and investment put back into kind of more preventative parts of the pathway. I think we've had some assistance from the ICS and the place-based director in Bexley around the funding for Bexley CAMS, which has enabled us to think a bit more about where we want to go to with that service. And I think in Greenwich and Bromley, it's been fairly quiet actually, and Greenwich are very much taking the approach that they want to work with us on a joint review of the value of the social care offer into adult services. So, but I think the context, as Matthew's described, remains. There is huge pressure on these budgets. We've been relatively protected for a number of years, so I think it is very difficult to actually, push back always against some of these requests. But we do need to be thinking about it in the context of integrated service delivery. So it needs to remain on there, but it's not something that's going to go away anytime soon.
Thanks, Ian. Next one, responding to service delivery concerns. I mean, there's detail in there about how we pick up a range of these things. Service delivery concerns that come through. I mean, it always feels a slightly non-specific risk in that, although it's very definitely a risk, and I think it's one that the CQC would probably expect to see reflected on our BAF. I don't know if anyone had anything they wanted to call out specifically on that one. I know we've still got ligature risk to come, so I'm conscious of the time. Okay, and then we've got the impact of COVID on staffing levels and staffing pressures, which I think, as we've said, that's well mitigated. We're reviewing that at the next exec. I'd expect to see that either change or be withdrawn at the next exec, because it's not an issue for us at the minute. Although it's likely to come back when we get the next wave in the late summer. And then final one, ligature risk management. We're still waiting for the CQC inspection report from their older adults visit. You can see in there is a comprehensive programme of work underway on ligature risks, and I know as a board we've spent a lot of time talking about this recently, but very happy to take any questions or points on that. Okay, if not, Andy, is that
well done, Matthew. Thank you very much. I know that was quite lengthy, and you slightly exceeded the 10 minutes that was allowed. But I think that was really, really helpful. And I think, as you say, you're going to review this with the exec, and I think rightly so, to tidy up and to take on board some of those issues that have been mentioned, particularly around the completion dates. I think it is really helpful. It's captured a lot of vital issues. I think you deserve a break. And so where are we now? What's the time? It is 11:47. If we could come back at 12 o'clock, is that fine for everybody? 12 o'clock we'll resume. We will be sharp. We won't miss anything of importance, but we'll be precise, assume everything's been read, and take us straight to the point of the issues concerned, please. Thanks very much. See you at 12. we're on to item 5, which is the Chief Exec's report. Matthew, please.
Okay, thanks, Andy. And as part of this, we're going to show a short film with Steve's technical assistance. I think the key points in the report, I'll just briefly say COVID, as I said, significant reduction and largely back to normal in terms of activity, and inpatients very low, and vaccination is well on track. And we are just keeping an eye on the guidance about use of PPE, etc. in the workplace. We'll obviously have to continue it in some areas, but for some of the more general office areas, we need to be conscious of what's happening across broader society. So we'll just keep watching eye on that. We'll update the guidance as and when. National planning at the minute does suggest there will be a third wave in late July into August, when we'll see an increase in infections as a result of more movement around. But because of the vaccination factor, whether this translates into hospital admissions and ICU admissions and deaths is not at all clear. It should be at a much different level. So we'll have to keep a watching brief on that, and we'll keep the board fully updated. There's updates in there on building a fair Oxleas, and some of the excellent work that Rachel and her team have been leading through that's working out across the trust, including some information there also about our 2 new staff networks, the Women's Network and the Mental Health Staff Network. And there's been a couple of very good pieces on Oxwide that I'd commend to people to have a look at, interviews in that. Neil and I did one with Kelly, who's leading the Mental Health Staff Network last week, that I think is worth a watch. Global Nursing Conference, thanks to Jane and her team for pulling that together. I think we're signing up an agreement with the University of Nairobi and University of Greenwich at the end of this week as well. And that's offering us recruitment routes for people, and there's some really interesting work in that. And you can see some of the information about the conference on the Ox. And there's more information on there on the Trust Directorate structure. We're about to start recruitment for the 2 Service Director posts, and we've brought in borough partners and others as part of the recruitment process there to support us with making sure that we get the best possible people into those lead roles. And Ian's chairing a project group to steer this plan through with the aim of introducing the new structures in September. And as I mentioned earlier, CQC, we're still waiting a report on their inspection. And worth noting that our colleagues in SLAM are currently undergoing an extensive inspection of inpatient units and community teams, and CQC are piloting their new methodology. And David Bradley's been sharing some of the experience of that, and we can give an update to the board on the new CQC approach at a point later in the summer once that's clarified. So I think they were all the key points from me. What I was going to suggest, we've been doing a couple of pieces of work with Sky News recently, and they recently did a short feature on our district nursing teams. I was just going to ask Steve Cooksley just to run this for us. I know some of you will have watched it, but I'd imagine some of you haven't seen it as well. So Steve, I always say this with eager anticipation of the sound working or not, but can we run VT and see if it works? Thank you.
Hiya, Pam, it's Harriet, the respiratory nurse.
Pam suffered a stroke on Boxing Day. Very soon afterwards, both she and her husband Ron became infected with coronavirus. They travelled to hospital in the same ambulance. They lay next to each other in the same ward.
Number of issues that might fall within the cracks between committees, and that we needed to look again at governance. Where have we got to on that piece of work?
I think we've got quite a large item on that at the strategic board session in June, I believe. I think that there's a broad piece of work around safety that we've talked about here, both including the new methodologies that we're running through nationally. And Jane and Effie and I have been talking about bringing something to the June Strategic Board. I don't know if any others of the exec wanted to chip in on that, because I know we've been talking about this quite a bit. Because one of the proposals had been potentially for a subcommittee to pick up some of this in the meantime.
Yeah.
I must confess I've slightly lost track, other than to say that I know we've got it on the agenda for the next board session. Ian.
Hi, sorry, Nina. Yeah, I think the idea of a subcommittee is still what we're planning to take forward. And it's something that Rachel T and I have started to discuss, because I think we see it as our kind of joint responsibility. I think in the meantime, I'm making sure through the monthly service director meeting that I have that this is a standing agenda item. So we're creating a bit more visibility about health and safety issues within each directorate, but also making sure that there's oversight of some of the measures that we have in place to keep people safe, particularly around things like lone working. But I don't know if Rachel T wants to add anything to that.
I don't think anything specific at the moment, but there will be an annual report coming back to the exec, I think probably in July as well, which will go to workforce beforehand, so we can have that conversation with Nina in advance.
And I welcome the additional visibility that you just touched on. I think my observation from the workforce perspective is that we've had less visibility than what we used to have. So I accept that there's been things happening in the background, but if we can just look again at the question of board level governance, please.
Okay, thanks, Nina. And Suzanne.
Thank you. It may just be me as a Ned, sort of feeling that I'm not very clear about what's happening at the ICS level, other than when it kind of impinges immediately on infrastructure and capital expenditure. But I'm just wondering whether it'd be useful if in future there are a segment of your Chief Executive's report, Matthew, that briefed us on not just what has happened in the ICS, but also some of the issues that you see emerging. Because it seems to be such a critical part of our position as a trust now. And at the moment, there's relatively little information about it coming to board.
I mean, I think at the minute, the only real discussions that are happening with the ICS are about the money at the minute. So if I was updating today on it, it would have been everything we've heard about the finances, because there's been no headroom really for much beyond that in the last couple of months. But I think that'd be a useful thing to do. Perhaps, we can do it as a standing thing on the CEO update. It's also a big part of what we discuss at Partnership Committee as well, and what comes through that. So I think I'll take advice on if we want to cover it off in both Partnership Committee and the CEO update. I'm happy to do it in that way.
I think your update would be helpful. And I have various chairs meetings. To be frank, there isn't much to report at the moment, other than what Matthew's talked about as far as the money is concerned. There's lots of rumour going on, but unless you know more than I, Matthew, I'm not hearing anything concrete. There's discussions about the composition of the partnership board. There's various pushbacks about the representation of mental health on the oversight over the board itself, but there's nothing definitive that on the meetings that I go to report back.
Okay, we'll make sure. I'll talk to Sally, and we'll always put it on my update as well. Even if the update is nothing's moved on much since last time round, I think we can do that, and we'll keep bringing it to Partnership Committee as well. Just
go back to the health and safety for a moment. Now, I know everyone's been extremely busy, but we have been knocking around with this for a while, and even if it's not perfect, I think moving to some sort of subcommittee structure quite quickly, even if it's it would just get on with it quite soon now, so that we're bringing all health and safety things together. I'm sure we can look at what other trusts do as well, but we've been looking at this for some considerable time, and I'm feeling quite uneasy about it, particularly in light of what Nina just said about seeing less of it rather than before. So I'd be grateful if we could speed up on that. the embassy wants to come in.
Thanks, Andy. Matthew, in your report, you talk about the new trust directorate structure. How are you proposing to keep the board assured of how that's going in terms of accountability, governance running all the way through, having sufficient workforce in each of the different directorates? I note there that you do have a project team and everything's supposed to go live in the autumn. But I'm just wondering whether it'd be a good idea to keep the board abreast of changes and ideas before we go live in autumn.
Yeah, I think we'll certainly try to do that. I mean, it's a standing. I've spent quite a bit of the Tuesday NED briefings talking about that, but I know they are not a sort of formal, structured part of how we update people. So maybe for the July board, we should bring a paper to that for discussion about what it looks like. I mean, I think in terms of scale, it's worth. There's I think 50 posts of the 4,000 that are directly affected by the changes in terms of changes to that structure and content, but then there is management responsibility change underneath it is the much more significant part of it in terms of the lines of sight we've talked about already around things like acute and crisis pathways and CMHTs. So what I'll maybe do is talk to Ian about how we bring a report from the project group to the July board, because that's probably going to be the last opportunity for us to have a really good kick of the tires as well before it goes live in September as well. And if we need to do anything interim to that as well, I'll be very happy to think about how we might bring that through.
Thanks.
Yeah, Rachel.
Just to mention that I was also planning on providing an update at the next workforce committee, so that's another opportunity to talk it through as well.
Okay, thanks very much. Anything else from you, Matthew?
No, nothing else from me, thanks.
Okay, Ian, please, thank you.
Thanks very much, Andy. So I'm going to take it that colleagues have had a chance to read the operational report. There's quite a lot of detail from each of the directorates around some of the kind of key challenges and achievements since the last meeting. Plus, I've added in an update on the work around veterans as well. So very happy to take questions around any of that. On top of that, I just wanted to highlight a couple of things. One is around COVID from a more of an operational perspective. Matthew's obviously covered some of that in his update already. And then I just wanted to touch on a number of the exceptions on the IBR, if I may. So in terms of COVID, as of yesterday, it felt that we kind of achieved a significant point in that there were no staff with a positive diagnosis, no inpatients with a positive diagnosis, and only 6 in total suspected cases of COVID within our prison services, and that's all of our prison services, London and Kent. So that felt quite significant in terms of where we are in that kind of continuum of the last year, and given that that's you know, the COVID and the pandemic has been you know, something that's preoccupied all of us, particularly those of us in the ICC. So that's a very positive thing. And Matthew's also mentioned about our work to vaccinate staff. As of yesterday, I think I'm right in saying, Jane can correct me if I'm not, that around 76% of our staff have now been vaccinated. Just to put that into context, the South East London average is around 77.9. So we're in the right ballpark with that, which is excellent. And a huge amount of work has been put in by Jane and her team, but also Ellen McGowan to make that a reality. So I just wanted to highlight that. In terms of the IPR, I have mentioned this at the last PQAC, but there feels to be a handful of performance indicators where we're a bit stuck in terms of having negative exceptions, and those are there's a couple of operational ones which relate to mental health around 72-hour follow-ups for those in scope for that following discharge from hospital, and the second is around 6-month CPA reviews. And then on top of that, there's something for me about the consistency of around supervision and the way that that is managed across directorates, and also responding to complaints where we're again seeing quite a lot of variation in terms of working within the agreed timescales. So rather than kind of continuing as is, I felt that we need to do something different. So I'm going to start monitoring those indicators through my monthly meeting with service directors. We've got a discussion, initial discussion tomorrow, where I've asked the service directors just to give me a bit more information from their own perspective about what might be happening, and then we'll come up with a concerted plan to shift these things in the right direction. I mean, I think things like supervision, this has happened previously. We can get on top of it, and it will get better. And I'm pretty confident as well about the follow-ups and the CPA reviews. I think responding to complaints is a tricky one. We've talked a lot about this at board and PQAC before. We've tried various kind of QI initiatives, and I'm not quite sure that they have worked where we've targeted them at particular directorates. So I think we just need to kind of look at all possibilities really, because it feels uncomfortable to me to keep having these on the kind of agenda of the board and the subcommittee as kind of as consistent themes without doing something different to get on top of them. So I just wanted to highlight that, and hopefully at future boards I'll be able to report back on an improved position. So I was going to stop there, and happy to take any questions about anything I've said or anything that's in the report itself.
Stephen Dilworth, please.
Yeah, Andy, and thanks, Ian. I'm not going to ask you about the 72-hour discharge. I'm sure others will, but I know you and I have exchanged some thoughts on it. Two questions from me. First of all, on the hydrotherapy unit at Goldie Lee, certainly this has impacted in our consideration at top level about possible developments for Goldie Lee. So, but I'd just be interested in your thoughts as to the value of the hydrotherapy unit. Is it something that you feel we must keep? I know it is well used, but any views you've got on that would be handy. And secondly, you touch on the eating disorder programme, which again, I know is a programme going from strength to strength, looking to be expanded. You touch on the SLP level of investment there. Could you just give us a feel for what the scale of that investment is? Thank you.
Yeah, thanks, Steve. So if I take hydrotherapy first, just a slight change to what's in the report, actually, in that within children and young people's services, we've now started to see some limited return of patients to the hydrotherapy pool, but obviously working within the risk assessment that Lorraine Regan undertook. So the service is hosted by ALD, but it is used by both ALD and CYP. I think it is a service that is highly regarded. I think service users value it, and I think staff within the two directorates feel that it should be a core element of what we do. In terms of the local context, the only other hydrotherapy pool kind of nearby is down at Orpington. That also remains closed at the moment, and as I understand it, there are no plans to reopen until September, and I think there may be some kind of additional estates work needed around there, because I think one of the things we've explored previously, Steve, is whether do we keep our hydrotherapy pool, or is there an option to kind of to think about this at scale and go in with the provider down there? But I think until it's a bit clearer about what is happening at Orpington, we want to kind of keep going with Goldie Lee, but it's certainly something that we should keep under review. And I suppose it's, from my point of view, it's just kind of keeping that operational perspective, feeding that into the infrastructure committee perhaps, and you know, you and I perhaps can have some conversations about that outside the board. In terms of eating disorders, I mean, our relationship to the SLP programme is kind of different from SLAM and South West London in that we are not a provider ourselves. in terms of patients who have an eating disorder, they make use of what's provided by SLAM. In terms of the kind of value of these services, the provider collaborative element, which is the inpatient element, I understand that that contract value is about 6 million for the population of South London. But in addition to that, SLAM also treat patients from outside of the South London footprint. So, and that generates income. It's actually much greater than the 6 million, but the proportion that is for South London is 6 million. And then on top of that, each of the ICSs, so South West London and South East London, also finance day services and kind of outreach into the community. So for us in the BBG footprint, again, that would be provided by SLAM. What's been very positive about the recent discussions with the ICS in terms of the recent planning cycle is that BBG are going to be allocated an additional £200,000 for BBG service users. So I think there's a real opportunity that we want to take, and I'm working very closely with Joanne Wallace, who's the head of nursing in Greenwich, who's also I suppose our most experienced in terms of being an eating disorders clinician. She's worked in eating disorders previously, and she links into the SLP work stream. So she and I are working together to kind of articulate with SLAM how we best use that additional 200,000, because I think there is something about perhaps the geography and the fact that services are located up at Denmark Hill, which works against kind of the needs of people more locally. So we want to kind of look at what might be possible in terms of using that money. So hopefully that answers your question.
Thanks very much, Ian. I don't know which order people came up, but can we start with Nina, please?
I just had a quick question, Ian, please. You talked helpfully about the vaccine take-up at staff level. Do we have a sense of, sorry, I can just see Matthew's sent. Matthew seems to have answered the question on the chat. I just wanted to know if we were classified as a problem area in terms of having low take-up rates in the communities and the populations that we serve. I'm seeing from Matthew's comment that that's not a concern. Is that right?
Bexley and Bromley are doing extremely well with vaccination uptake. Greenwich is doing well, but slightly less so than Bexley and Bromley. And as a general theme, our 3 boroughs populations are much higher in terms of uptake than the 3 inner London, Lewisham, Lambeth and Southwark. South East London as a whole, I think, is doing well as an ICS in terms of vaccination uptake.
Okay, brilliant. Thank you.
Suzanne, please. Suzanne, would you?
Sorry for the slight delay. My Teams is running a bit slowly and didn't want to unmute me. Ian, I wonder if you could just allay an anxiety I have about the reference to DNA CPR training for the ALD teams. That I don't know why it's been offered specifically to ALD teams, and my anxiety is that this might be read as meaning that we ought to that people with a learning disability should be put onto a DNA CPR, rather than possibly what I think this may be about is a response to some of the anxieties which have been raised and the report of CQC that people with a learning disability were being inappropriately steered towards a DNA CPR. So perhaps you could just comment on what that reference is in the papers. It's on page 36.
Yeah, thank you, Suzanne. I mean, there is a context, and I think you've alluded to it, that in our work with acute hospitals, there has been a kind of concern around ALD still being, LD still being used as a kind of reason for DNA CPR, and that's something that we look to influence, and we have kind of structures and ways of doing that. So I think the training is to support our staff in having those conversations with the wider system, and particularly physicians and physical health teams. So that's my understanding of the situation. But I will check out with Lorraine if there's anything I've missed in terms of my answer.
I'd be grateful if you could. I know that this is creating a lot of anxiety within the community of learning disabled users and their families.
Thank you. Jo, please.
Thanks. Just a couple of questions on your report, Ian. So the first is in relation to the work that's going on in Bromley with the primary care network, where we're sort of putting nurses into primary care setups, so hopefully to reduce the pressure on PCP and also to facilitate people coming off our caseload and back into primary care. I don't know if you want to comment on how well that is going and whether you think that's a model that we could use elsewhere. So that's my first question. So that was on page 43 and 44. My next one is a very brief one, which is about the increase in violence and aggression in the forensics division, and what do you think the driver for that is? And then my final one, and that was on page 48, my final one relates to page 50, and this is the increasing weights in neuro rehab in Greenwich. I was particularly drawn with stroke responses, and I see we've put in a comprehensive business case to the ICS to sort of deal with these issues, but I just wonder, you know, how likely it is we're going to get funded for that, and what's plan B if we don't? And that was on page 50.
Thanks, Jo. Just writing them down so I don't forget any of them. So yeah, I think Abby alluded to the fact earlier on that probably our work with the PCNs around mental health in Bromley is a bit further ahead than certainly Greenwich, but also Bexley as well. And that's partly, I think, just because of how the PCNs themselves have formed and the speed at which that's happened. I mean, what it says in the report is the fact that as part of the long-term plan, and these are funded posts, each PCN has a practitioner. So these are new posts. I think one of the interesting things is that PCNs are different, are kind of constituted around different sizes of population. But the kind of guidance at the moment is that each PCN will have one worker. So that's why Bromley ends up with 8, but Greenwich will only end up with kind of 5, and Bexley will 4. So it doesn't necessarily mirror the kind of population. But these posts, when they come in, will really be about trying to help that interface between primary and secondary care, some of which will then lend itself to kind of managing demand. But the other more kind of fundamental bit, I suppose, is to help general practice in managing some of the activity that perhaps flows through to secondary care. We know from the benchmarking data that Oxleas, we have a much higher acceptance rate of referrals into secondary care mental health than other similar providers. I was talking to South West London the other day, and I think their acceptance rate is something like 14%, but they spent an awful lot of time in the kind of processing of those referrals and batting them back, if you like. Well, batting back's probably not the right word, but, you know, putting them somewhere else. So I think we need to kind of create a reasonable infrastructure around that. The work with Mind that is in there is something we are looking to replicate across all 3 boroughs, and it's on the agenda of our VCS partnership group, which we now have, which both Bromley, Greenwich, Lewisham Mind, but also Bexley Mind are a part of. So I think this will be really important. I think it will be better for service users, and it will really help in kind of managing that flow into secondary care. And I think what Lorraine's highlighted in the report, I would expect to see happen elsewhere as well. In terms of the violence and aggression in forensic services, I think this has been driven in large part by the repurposing of the Heath. So as part of the kind of SLP conversations, work started last autumn to reconfigure the Heath ward, which up to quite recently was a female ward, to a male ward, because that's what the demand in terms of the kind of South London has dictated. One of the things that has happened as a kind of consequence of that is that we have seen an increase in the kind of incidents of aggression and violence towards staff, but also between patients as well. A recent CQC monitoring meeting, internal meeting, Jazz from the QA team kind of presented a report of findings around that. So I think there is something about how we support staff in terms of de-escalation and working with a different client group. So I think it's something that I'm concerned about, but I'm kind of confident that we will get on top of. And I mean, in the context, as you know, of the BRAC, more widely in the Bracton, we have a really good kind of structure, I think, around dealing with violence and aggression, which has been very successful. So I think it's just embedding that in the new context of the Heath. And I didn't write down your third question. I'm very sorry.
It was just about increased delays in Greenwich Neuro, and the fact it says on page 50 we've put a business case into the ICS to deal with it. But I was just a bit sceptical about that being funded and what our plan B might be. I think you're on mute.
You're on mute.
Apologies. I think Azra has already mentioned earlier that our wish list for community services is going to outstrip the funding that's available. But certainly Neuro across Greenwich and Bexley was kind of high up on that list. The other bit of context around this is that we've been engaging alongside all the other community providers in South East London. There's something called a Community Provider Network, which Matthew actually chairs. But as part of the work, one of the kind of outputs from that group is to look at what the core offer should be around neuro rehab across South East London. So I think what that's highlighted is that there is quite differential practice between providers. Some of that is driven by differential levels of funding, but I think if we don't get all the funding that we need, or I think there's an opportunity through engaging in those conversations to look at and see if we do something different. But I think it is, in terms of our community health services, it's not far behind district nursing in terms of kind of concerns around demand and capacity. So I will, I'm keeping an eye on it, and I'm sure I'll return to it in future board meetings.
Thanks, Ian. Amlan, please.
Thanks, Andy. Matthew, thanks for your comment just there on the chat. One of the questions I had was just about whether that DNA CPR training is appropriate, not just for our LD teams, but perhaps some of our other teams, because in our experience, we've had even people with progressive neurological conditions or simply just age discrimination be involved in some pretty unpleasant conversations. So is there a scope to expand that perhaps to other services like old age, for example?
And sorry to jump in, but I thought, Ian, while you were talking, I gave Lorraine a quick ring there just to check the exact context. And she said it was, if anything, our LD teams were being a little bit too overzealous in assuming that some of our partners were inappropriately using DNA CPR. And having gone through a number of cases, they then did an audit to check and found that they were actually being appropriately and sensitively used. So it's more about bringing the right clinical and patient consensus together. But that we've found no evidence of their inappropriate use in terms of the cases that we've audited locally. I think it would be worth putting that into the minutes, and we'll maybe just ask Lorraine to do a paragraph or two more on this, and then to Amlan's point, to think about it slightly more broadly. It is a difficult issue. The conversations, I think, are difficult for anyone who's ever been involved in them as well, with families or others as well. So I do think we have a good approach to it. It's quite nice to say we're training people to rein in their patient champion zeal and make sure that we maintain those proper respectful relationships with peers. But I'll pick that point up further with you.
Thanks, Matthew. And my second point was just as Stephen, I think, alluded to before, Ian, that someone was bound to ask you about the 72-hour breaches. So without wishing to disappoint, can I just focus on that for a sec? Clearly, this, that's worrying because, as we all know, the 72-hour time period is just so critical, isn't it, post discharge? And some of the reasons, I guess, for the 72-hour breaches seem like simple fixes, but I just wanted the opportunity for us to minute at this meeting what actions were being taken around that, which I think you alluded to in brief before.
Yeah, thanks, Alan. If you've had an opportunity to review the information that's in the COVID report, that gives you a breakdown by borough about the performance over the last few months. So my concern is that we do see an improving trajectory, but then it is not sustained, and it seems to be variable across boroughs. So you might have months where it's fine in a couple of boroughs, but not in a third. The numbers in scope are quite small, but as you say, there's a reason for having this as an indicator because it's so crucial clinically. Without wishing to preempt the conversation I'm having tomorrow, I think there are a number of kind of process issues that are kind of being highlighted, and some of them are simply down to human error. So, for instance, notification that discharge has taken place, and then when that notification has been kind of responded to, it's been beyond the 72 hours. Others are kind of practical issues about have we got the right contact details, etc. The thing I was more concerned about, and I'm wishing to explore, particularly with Bexley, is that when this new indicator came out, we felt pragmatically that we could put some of this activity through the crisis line, which is hosted in Bexley, as a kind of way of pragmatically speaking to people quickly, and then if necessary following up face to face in the community. And what I'm not clear on, and hence the conversation tomorrow, is that realistic for them to be able to do that alongside the other activity that's going through that? So there's some data that we're looking at tomorrow, but I think the first points I made, that is just about tightening up process. In a set, it's not dissimilar to conversations we've had previously about 48-hour follow-up, which again was for a slightly different group of people. We just need to attend to it, get on top of it, and then sort it out. But I think the opportunity tomorrow is to see if there's something more fundamental we need to shift in terms of where this activity goes. So I will report back, definitely.
Thanks, Ian. Thanks, Ian. Were there any more hands up there that I may have missed? If not, if there's no further questions for Ian on that, I'm very grateful, Ian. Thanks very much. We'll go on to Oxleas strategy implementation. Matthew and Rachel.
Thanks, Andy. So I'll take this if that's all right. So we agreed the new strategy for Oxleas at the last board and at the Council of Governors, and our challenge now is to put it into reality. And the purpose of this paper is to make sure that you as a board are happy with our plans to give you oversight in relation to both approach and progress. So the proposition is that each strand reports on a regular basis to the board, and you can see the timetable, that we have clear executive leads for each area so that we've got clarity of ownership and accountability. And that's also set out in the table, and that each area comes to the board setting out clearly the case for change, the approach for delivering improvements, the timelines of the deliverables and the measurement strategy, as well as the governance approach, but also some thinking about how we really proactively engage staff and service users in all of this work, and other ideas that we might bring about injecting fresh and innovative thinking. So the idea is that we focus on each of those elements in turn at the board. That's the main purpose of the paper. It also provides for you the shiny version of the strategy document as it's all been laid out. There's also a one-pager that works as a poster, and we have an animation as well. It also sets out the communications activity that's been underway and our approach towards resourcing and how we're aligning with other policies and strategies. I'd welcome any thoughts and any questions. Thanks.
Thank you, Rachel. Stephen Dewar, please.
Thanks, Rachel, and thank you for a very comprehensive report and thoughts. Just one question from me. In terms of our big priorities, where we talk about a great place to work, and we're all signed up to the advantages of that around recruitment and retention and staff commitment. Can you just tell me for external stakeholders, so this is really for potential recruitment of new staff, how would they know we are a great place to work?
Thanks, Steve. It's a really good question, and one I want to think through in some detail, I think, before I come back to the board with the really detailed plans for how we measure this. But my first thoughts would be word of mouth is really powerful in this context. I think we're often competing in the same pool, so we need to be known as a really excellent employer. Social media helps. People have networks of contacts right across the NHS, and they know what it's like to work in different trusts. So we need to be sure that the people who work at our organisation have a really good story to tell. I think there's something also about us being seen and perceived as thought leaders, that this is an innovative, creative place to work where we've got real ambitions, and I think zero delays and great out of hospital care can really help to raise our profile as a really ambitious and innovative trust. I think we need to think about how we advertise in terms of, particularly for things like prisons, if we want to be extending in Kent, for example, we need to think about what's the right way. And you've talked about radio, I think, Steve. What's the best way for us to reach those potential candidates that we might want to reach? NHS jobs is usually the one for reaching clinicians, but we need to think kind of creatively about that. But also in terms of our metrics, how we do on things like RES, how we do on DES, how we do on staff engagement. These things are noticed by other trusts and they become part of what people perceive about Oxleas. So hopefully all of the plans that we have as part of Great Place to Work help to really raise our profile and make us a really attractive employer of choice for people who work locally. Does that answer your question, Steve?
Thanks, Rachel. Jo, please.
Thanks. Yeah, I think my question kind of follows on from Steve's, because I picked up on when the presentations come to the board, and I think it's really useful to have a forward view of when we're going to get them. One of the things that we're asking them to cover is measuring progress, proposed approach and key performance indicators, which I think for that particular strategy fits in with what you just said. We need to make sure we know what success looks like. And with that in mind, I think I was being a bit picky, but I think we should have targets in there. So it's not just measures, we should have targets for those measures so we know when we've got to what we were aiming for. And I think we need to be bold on that. So that was just my point, is we need targets as well as measures. Thanks.
Thanks, Jo. Happy to add that in.
Thanks very much. Were there any other hands raised on this? I can't see any.
I did raise my hand earlier, but I put it down because I thought we moved away from the question that was posed to Rachel earlier. I just wanted to contribute a couple of things from a medical recruitment point of view, which is that we have been speaking to all the trainees, the hired trainees across Southeast London, just asking them what might attract them to Oxleas or what they would like to see, us doing Oxleas that would attract them. As a way of really trying to make Oxleas a more attractive place to work. And the other thing we've been doing, of course, is to talk to those consultants who have moved, because in recent years it's become common practice for consultants to move compared to, say, 20 years ago, where it was the case that if we were appointed somewhere, you pretty much stayed there until you retired. And we kind of ask, what brought you to Oxleas? How have you found Oxleas to be what you expected? What's good about Oxleas, what could we improve? And I think that all of these are ways in which we can continue to refine and improve what our offer is, to improve how attractive we are as an organization. And I'm sure that there are many other ways of doing this across professional groups.
That's very helpful, Liffey. Thank you. If there's nothing further, thanks ever so much, Rachel, for that. We'll go on now to Jane, please, and the GLSI group.
Thank you very much. We shared this report and action plan our last board away day, partly because Dr. Michael Whitney had retired and he chaired the panel, and partly because we wanted to have a longer discussion around the systems and processes during our investigation processes. We heard that GL was a 43-year-old gentleman who was having an informal admission to Green Park's house. He had personality disorders and an alcohol dependency for which he was receiving support. He was also homeless and was being supported into secure accommodation, supported accommodation. But whilst he was away from the ward, he fell from a bridge and sadly passed away. From the investigation, the panel found no root cause, and following an executive review, Iffy and Lorraine met with the panel to review the use of least restrictive options and to establish that he had in fact been appropriately not detained under the Mental Health Act, which they ascertained. The recommendations have been progressing well. There were 3 recommendations. One was a review of the AWOL policy at the Mental Health Legislation Oversight Group, which has been completed to make sure that informal and formal admitted patients have the same duty of care. The next recommendation was about daily risk assessments for informal patients, so not relying on subjective information or perceptions that people are less risky if they're having an informal admission, and that's being shared across all of the directorates. And the third was around the individual ward and the process that they were using for screening for drugs and alcohol to make sure that there was regular screening going on. So the reports come back here for noting.
Thank you, Jane. Questions, colleagues? Suzanne.
Thank you, Jane. I just had a couple of queries about this, and it's in relation to the recommendations. So the first recommendation was about a review of the policy and how the review of the policy would be evidenced. But what's going to be done about ensuring that the policy, once it's been reviewed and implemented, is then kind of embedded in staff understanding of what we're expecting them to do? The other thing that I would just sort of comment on, because I think it's possibly a sort of slightly unfortunate use of language maybe, is that we talk about ensuring that informal patients are afforded the same duty of care. Well, they have the same duty of care. It's about us ensuring that we meet that duty of care. And I wouldn't wish a view to be taken that somehow the choice of whether or not we owe them a duty of care lies within our domain. You know, it's their right under the Human Rights Act.
Absolutely, I think it's the form of words that have been used, and your clarity on that is absolutely appropriate. So thank you for that. In terms of the policy, the Mental Health Legislation Oversight Group reviewed the policy to check that it did contain the information about making sure that risk assessments were the same for people who were detained and not detained, and it is actually in there. So we have confirmed that, and that is being shared with the teams through the Acute Care Forum where this is discussed. I think it's an interesting dilemma in terms of making sure that changes in practice occur, and what we need to make sure is that learning is taken forward and that we're checking this through our assurance visits and making sure that this is actually happening on the ground. And to do that is really looking at individual cases when the Improving Lives are out and about to check it's happening.
Thanks, Jane. Sue Salter, please. Hi, Sue. Did you want to ask a question?
Apologise. As they're informal patients, and obviously the criteria is more or less the same from what you're saying, is there a time limit on how long they're allowed out of the ward? And is there a remit for the staff or the person concerned who's out to contact the ward on a regular basis so you know they're all right?
Well, usually when someone's informal, you know, it's the least restricted admission, so you know they don't have to come back, but they always negotiate a time that they will be expected to come back or expected to be in touch. And if people don't meet that, then there's an expectation that reasonable follow-up is made to check that they're safe.
Yeah. Okay. Thanks. Okay. It's just I know of a case miles away from here with you know, a very sad outcome as well. So it's just how you ensure that patients are safe, the clients are safe, but it's a difficult one. I appreciate that. Thank you.
Jane, I was just thinking, I mean, as an informal patient, they can leave at any time, can't they? And sort of how long does our interest in them last? And when we talk about our missing persons policy, do we report informal patients to the police? And if so, I was wondering what sort of response we get for those patients.
We do have a responsibility to make sure that there's a risk assessment, and that if we have concerns about somebody not returning, that is followed up. And the police are usually notified of anyone that we're worried about. And generally, the response is pretty good. But sometimes we do have to make sure that we're putting in extra efforts to try and find people and contact them, which is reasonable as well, because quite often the community teams or the care coordinators who know these people will be able to identify where they may have gone and may have other means of contacting them. So we don't always rely on the police, but if there was a risk element, then the police would always be involved.
Yeah, thank you. I was just also looking at the other areas of learning, and it talked about patients should be seen by a ward consultant within a week of admission. I mean, that seems rather a long time, doesn't it?
I might ask Iffy to respond to this, but within the body of the report, I think it was just under the time frame that this patient would have been seen. Iffy, are you able to respond?
Yes, so quite a few years ago, I don't know if you recall, Andy, following an independent review of a cluster of cases, we devised a kind of consultant minimum standards. And what we agreed at the time is that the consultant should see at the earliest opportunity, that's the precise phrase in this agreement, but in any case, within a week. And part of why we had to do it that way is, of course, there may be a variety of reasons why consultants may be away, including annual leave, study leave, or if they're called off to joint panels, etc., as was the case in this particular instance. But do remember, of course, that there are other doctors on the ward. And when consultants are away, it's fairly typical to have someone else cross-cover, although that other person has to do their own job in addition to cross-covering, and that can be a bit difficult. And it's one of the things that Ian and I have been talking about going forward, whether there might be some way of making sure that we can get consultants who will actually be physically present covering when someone is away. But you're right, it sounds like a long time. But from my personal perspective, if you see someone once a week and you assess the risk and you set the plan and the team understand it, that's usually fairly okay on an acute ward. If it's an intensive care unit where things are changing more rapidly, you could argue that that may not be enough.
Yeah, thanks, Iffy. I mean, I missed out the piece on that, on the cover sheet which said or approved clinician, and it just struck me as a layperson that they might be seen very quickly on arrival on a ward, and then maybe a week after that, perhaps. But and the absence of a consultant, well, yes, as you say, one would hope would be covered by some other person while they're away. I'll just go on to Ian now, please.
Sorry, Andy, I've been putting my hand up and down. I suppose it was just going back to I know there's been quite a lot of conversation about this report at various meetings, but it was just to go back to that point about informal patients and their movements on and off the ward. I mean, I think part of the difficulty is about language and with this, because obviously the concept of leave doesn't apply to people who are informal. That's the whole point, that it's a negotiation, and obviously it's about if we have concerns that the situation has changed and we feel that the negotiation isn't going the way it is kind of supporting their best interests, and they may not have insight into that. It's about how do we respond to that, and obviously what legal framework there is. So and I think it just goes back to Suzanne's point. It's not about framing this as we somehow treat them differently from formal patients in terms of our duty of care, but it's simply around the kind of framework that's available to us to kind of manage those movements on and off the ward. And a bit like if you were saying around the kind of what we've got in place in terms of minimal contact with doctors, in terms of our organisational memory, this was stuff that we also emerged from that cluster of incidents back in 2016. And I remember having a number of these conversations back then, because it's finding something that is workable operationally as well, in terms of the staff that work on the wards, as well as obviously making sure that we're not losing sight of the patient's best interest.
Yeah, it's a good point, Ian. I was thinking about that when you remember back in 2016, we occasionally had confusion between formal and informal. We had Section 17 leave for informal patients. We had escorted leave. And that haziness about who these people were and whether or not they could leave at any stage, I thought was really quite interesting. And that clarity for the member of staff at 3 in the morning about exactly what the status of this person is. Because I did feel at some stage we were detaining people who were essentially informal patients because we didn't want to let them go because they thought they were to risk themselves or others, which then doesn't really mean they're informal. It seemed to me you were informal all the time you agreed to stay here. The moment you decide you're going to leave, suddenly you're a problem. And I think having that, you're the experts, I'm not. I just felt the clarity over their status and what we can and can't do if they're not there. Amlan, please.
Yeah, I just wanted to pick up, I guess, having been involved in this investigation, the way that the recommendations are formulated. I have to say, in my mind, sometimes I think the recommendations might slightly miss the point in the sense that the recommendation is not that a policy is reviewed, but that actually something changes on the ground. And we might get there through reviewing the policy. But if we don't get the wording of the recommendation right, then the evidence that we then detail to try to assure ourselves that something's changed is wrong as well. So, we want to make sure, for example, looking at this report, that the duty of care to informal patients is the same as, whether they're formal or informal. The evidence of that doesn't come from minutes. It comes from, as Jane was saying, going to the ward and actually checking that is happening. In terms of screening for drugs, the point of the recommendation is that patients are regularly breathalyzed for alcohol use in line with the policy. So therefore, the evidence for that has got to be, well, how do we know that that's happening? Uploading a process to Datix doesn't tell us whether that process is happening or not. So I just think that we need to kind of move the recommendations on a little bit from committees and processes to getting assurance that something is actually changed at a ward level. So the question I think should be, in terms of how this will be evidenced, is, as Jane was saying, we have a team that goes there to do an audit or a peer review, and then we can be assured that something meaningful has changed. So it's just a reflection on how we think about our recommendations and genuinely how we get any assurance that something has changed as a result of a policy changing.
And Jane, I was just wondering if you might expand on the answer to Amlan's question into what we're going to do about taking recommendations forward in general, because this has been a bit of an ongoing issue for a while, about giving assurance that we are managing these, making sure they're done, and also being quite tough about what recommendations we do take forward, so we don't have a multiplicity, sometimes overlapping recommendations.
Yeah, it's an excellent point, and we've been exploring this as a team recently, ready for the Board Away Day next month. I've drafted a paper which is looking at this. We want to use the quality framework, which looks around planning control and improvement and assurance as a way of looking at all of these. And I think Amlan's hit the nail on the head that the emphasis does need to be on making sure that there's an improvement there, but actually the real focus is on the assurance and how we're monitoring that as well. So it's a bit of a cultural shift in terms of how we develop the recommendations and how we thematically review them and how we prioritise them, because at the moment we seem to have a large number of, as you say, very overlapping recommendations that actually, if we look at the themes behind them and we look at what collectively needs to be done to change our behaviours and practices and make those improvements that people engage in and understand in, and then it's about following those up.
Thanks very much, Jane. We'll look forward to that. And thank you for your report. If there's nothing else for Jane, we'll move on to the equality diversity with Rachel, please. And this is for approval, is it not, Rachel?
Yeah, that's right, Andy. It needs to be published. So this is the equality delivery system. It's an important annual reporting requirement, and it relates to our role in relation to equalities and health inequalities. We've had detailed discussions at both Workforce Committee and Performance and Quality Committee. It is a compilation of contributions from right across the Trust, and so it's not something that my team can take credit for. I'm very grateful to everybody who has provided the text for us, and there is a lot of detail in there. And if you have detailed questions on it, I might well need the help of my executive colleagues in answering some of those questions. I will say that our preference would have been to have a much more active engagement with service users, local communities and staff than we were able to do this year. We did last year and we will do that again next year, and we will do that before the next iteration. It is a self-assessment, and we have tried to be as fair as we can about the areas where we have some relative strengths, but also where we want to do more. I know that some people think that our self-assessment is a bit harsh, but our sense has been that where we've known that there is more that we want to do, we should be really clear about that. And so we've assessed ourselves as developing in relation to areas where we think there is a lot more that we want to be doing. So I'm not going to propose to try and summarise what is quite a complex document, but I'm very happy to try and answer any questions that people might have.
Thank you, Rachel. Stephen Dilworth, please.
Thanks, Andy, and thanks, Rachel. Yeah, very detailed document, as you say. You asked for suggested improvements, so I realise this might not necessarily go into this format. I think the text was a lot stronger where we evidenced the outcomes. So, say pages 6 and 7 as examples, there's plenty of data in there. But if you look at pages 2 and 3, it's quite light. I'm particularly thinking about the SLP, actually. You know, we've got plenty of evidence, CAMS, 32% reduction in bed days, complex care, 100 step downs, out of area placements, the travel is reduced from 73 miles to 7 miles.
Yeah.
I think that would all make the document a lot more powerful. So, as I say, I appreciate maybe too late for this particular text, but particularly I think on the SLP, there is a lot of very good evidence that would put us in a higher and better category, and worth using.
Thanks, Steve. I'm very happy to add in some of that data that relates to the SLP into the document before it's approved, before it's published, if the rest of the board are happy with that.
Okay, I'll pick that up.
Thanks.
Thank you. Suzanne, please.
This isn't a detailed question, Rachel. It is actually about the value of this. It obviously takes an enormous amount of work. And I'm wondering, from your perspective, what it generates by way of conversation, change, learning, progress, any of the things that we might kind of hope, or you know, is it just a kind of checklist that helps us to stay on board? Perhaps you could just comment on, you know, how you see its value.
Thank you. I do think it's a useful process actually to see it all in one place. And it informs two big bits of work. So looking at through that lens, I think gives us a bit of an overview of where we are in relation to building a fairer Oxleas and some of the improvements we want to be making internally. Obviously, the data that's recorded there is information that we're already monitoring within that context. So whether or not this particular iteration of it adds particular value, I'm not sure, because it's data that we look at quite closely. We are, as you know, one of the building blocks in the strategy is around tackling service user inequalities, and that's a really active discussion for us at the moment. So Ian and Neil and Karen Edmonds and I have been meeting recently to really think about what the right sequencing is of the things that we should be tackling in terms of service user equalities, how we keep that focus, what, you know, we can't do everything all at once, and what are the right things for us to focus on in the first year, in the second year, and the third year. All things that we will be considering when we bring those papers to the board, when we're looking at that part of the strategy. So for me, I think it supports the Directorate Equality plans that we have. It helps to raise the profile of this within the organisation as being a really key priority for us. And I think we're a bit at the start of a discussion about what service user inequalities really mean for us as an organisation and how all of those elements really pull together. We know we've got pockets of really great activity, and you can see that in the paper, but I'm not sure that it's as consistent as we would like it to be. So generally, I think we found it a useful process.
Thanks, Rachel. Steve James, please.
Thanks. I just had a quick comment, which I think I made before, around the transitions paragraph. You talk about transitions between organisations, and I'm sure we have things that are in place for that. My experience is often where we trip up is transitions internally. It's often where somebody's being moved from one team to another. So partly I wonder if we are achieving that. And I think we have an opportunity in the reorganisation to look at minimising transitions, because the fewer transitions there are, the better it will be for people. So I understand that a lot of this is about transitions from other organisations and how we work with them. But I do think that we need to do some more work on internal transitions, because, as I say, my experience is it's often where we trip up.
I think that's going to be a really important part of the great out of hospital care work, actually, Steve, is really working out that whole patient journey and looking into that. So I agree.
Thank you very much. Thank you, Rachel. Do we approve this report? If I don't see any comment from anybody, and I do not, that report is approved. Thank you very much indeed. If we could go on to the annual staff survey, Rachel, you're back on.
Yeah, me again. So this paper sets out our staff survey results. I will say that I do find the delay before we get the results and before we can discuss them really quite frustrating, because by the time we are able to access and discuss and talk about these things with our teams, the views can feel a bit stale. So people complete these things in October and November, and it's months before we get that all processed and sent back to us. Nevertheless, I think it's really important that the time that people take to provide their views is really taken seriously by us as a board and as an organisation, and particularly that action is taken forward on a directorate basis. Now, in terms of the headlines, while the completion rates have gone down, the results are the same or slightly better than last year. So they're not the substantial improvements that we're looking to make over time, but they are nevertheless small and welcome steps in the right direction. So there are areas where we outperform in relation to the average. So that's for immediate managers, for quality of care, for safety culture, for staff engagement and for team working. And those are all really important elements, I think, that we do well. But there are obviously areas where we are lower than the average too, although we are making improvements. So health and well-being, 5% improvement on 2019, but still below the average. And that's something we want to work on with our staff assemblies and a whole range of other initiatives to make sure that staff really take the time to take care of their health and well-being. And that's been really important over the last year. But we also know that we can be much better on bullying and harassment and equality and diversity. And as you all know, these are areas where we have started really detailed programmes of work that are in their infancy, but that hopefully with sustained commitment will start to deliver the sorts of changes that we want to see. So the paper highlights some of the things that we can take away from these results, and I won't go into those in detail, but going forward, the priority for us is that the directorate workforce committees are looking at these in detail and delivering local action plans. We want to increase the focus on health and well-being through our staff assemblies, and our biggest focus needs to be on making Oxleas a great place to work, rolling out our values and building a fairer Oxleas. Open to questions. Thanks.
Well done, thank you. I did see, I can't see the name attached to that one. Who's got their hand up?
Hi, Andy, it's Yemisi.
Oh, thanks, Yemisi. I figured. Yeah.
Thanks for this, Rachel. It was it was disappointing to see the completion rate, the fact that it's only 42%, you know, considering the strength that this survey has for staff and the benefits that getting their views across can have for us. Have you got any ideas as to why it is so low? I know we've had the pandemic and obviously, you know, people's attentions have been elsewhere. But I was thinking, have you got any ideas of how we can get this up, or maybe increase communication so we, you know, more staff can fill it out and we can get a much richer picture of how people are feeling?
I think you're absolutely right, Yemisi, that the completion rates are disappointing, and previous year we'd made it, I think, to 52 or 53%, so it is quite a drop on the previous year. I do think that the context is important. We were doing a lot of surveys about people's experience of COVID. I don't know if people felt a little bit surveyed out. We know that does happen, but it did seem important to track people's views of how they felt they were being taken care of through COVID. So that felt like a priority. The other thing that's always I find really frustrating is that there are two massive communication pushes that need to happen at the same time in the NHS. That's the drive to get people to have their flu vaccine, and then the drive to have the staff survey completed, and they fall at exactly the same time. And at the time that we were making decisions around this, there was a lot of feeling that you had to have had your flu vaccine before you could have your COVID vaccine, and it really felt that the biggest priority then, whether that's right or wrong, I'm not sure now, but that the biggest priority then was to really focus on the flu vaccine. So we did push it. I think we have done much better in the past at getting get those completion rates up. And I think there are a range of ways in which we can really drive that for next year, including talking about the differences that people's views in these things actually make in practice. And I think that's the thing that will really make the biggest difference. So I'm really hopeful that we can get to a much better completion rate for next year.
Thanks, Rachel. Suzanne, please.
Thank you, Rachel. That your final comment anticipated one of mine, which is about the need to tell people what differences have been brought about by completing the staff survey. It is a kind of equivalent to the sort of you said we did for staff, doesn't it? But the thing that I was curious about, and partly because I have a friend who's chair of a community trust in another part of the country, which has different difficulties to us. But she was crying about how brilliantly they did on the NHS staff survey, which did prompt me to consider our comparators. And I think one of the things that I would find interesting, and this may have been part of the conversation that you had at Workforce Committee, is that if we were to sort of take some of our most significant comparators, given that we are in a partnership with SLAM and our staff may be quite attracted to either working for SLAM or working for us, how do we compare with SLAM on some of the key indicators, and potentially just taking one or two other trusts to say, they're in a very similar situation to us, they have similar kinds of challenges, is there any major difference, and is there something that we can learn from them in terms of how they've managed to tackle some of the things which would continue to be issues for us. So I was just kind of wondering whether there'd been some kind of discussion of that sort perhaps at Workforce Committee or in other areas of the trust.
So we do look at the comparators and the benchmarks, but it does rather depend on which group you're put into. So I think we're put into mental health and community trusts, which means that we're not necessarily comparing with the people that we might feel in competition with in relation to kind of local workforce, for example. I know Matthew's got a bit of insight into where the other trusts are. I have a bit too, but Matthew, perhaps over to you.
Not that I'm horribly competitive, but I do always check where we compare, and we do outscore SLAM on every single indicator by quite a bit. And I think that's including prisons as well, which you have to say are a big anchor in terms of where our scores do sit as well. So, but there is certainly some. I mean, SLAM aren't necessarily a great comparator for us because of the inner and outer London dimension, really. South West London, St George's are probably slightly more interesting, albeit smaller, and they don't have the community health and prison side to it. So it's probably some of the integrated trusts, really. I mean, it's quite difficult to find sensible comparators to Oxleas in terms of the whole mix of scores, and it's probably more useful to do a bit more by breaking it down into the individual areas. I mean, CNWL have got a similar mix, but very, very different population context. And most of the other trusts don't have the community and prison sides, but we certainly do look at it. I look at it from the perspective of, do people want to come and work for us? And it's also, as Joe says there, it's to look at the directorate and staff group splits. I mean, you have some very different scores coming through from, for example, clinical services staff compared to AHPs who are extremely happy. Greenwich as a borough is the lowest scoring in terms of the sort of core services, along with prisons. CYP does very, very well, as do ALD and Bromley and Bexley. So I think that trust-wide, I think we do relatively well, but I think there's a space for that sort of more nuanced comparators and to see what we can learn from. My general sense is I think we do. I can't think the last time I heard about another trust doing something that I thought, I wish we were doing that, other than probably the NELFT for the goodie boxes, which I think was a really good thing that Oliver did up there. I've certainly had a number of people contact us about things like the staff, the shadow executive. And as I said earlier, a number of people who've read this strategy and think it's quite a different feel for an NHS trust strategy, one that makes sense to staff and one that you could work here and recognise the organisation in it, which I don't think many organisations achieve. But yeah, I do think those comparators are useful and to dig underneath it. But I tend to look at the high level scores on the doors before I text the other chief execs to see how they're getting on. It has been very notable this year that the mental health and community trusts have almost universally seen their scores increase, and the acute trusts have almost universally seen their scores fall. And that is a big, big national pattern. There was only a single figures of mental health trusts who saw their staff survey scores decline during the pandemic, and almost the entire opposite for acute trusts, which I think is quite indicative of where some of the pressure of the pandemic's been felt.
Thanks, Matthew. And really good to hear you're not competitive with our neighbours as well.
We're all in this together, aren't we?
Thanks very much. And Rachel, there's nothing else for you. Thanks very much on that report. We'll now move on to the annual report, and sign off self-certification process with Azra and Sally, please.
Thank you, Andy. If I can take this. This paper is being brought to the board so that we can have formal delegation to the Audit and Risk Assurance Committee for the final sign-off of the annual report draft and the annual accounts, and also our self-certification on the NHS provider licence. This is a process that we've done in previous years so that we can meet with the necessary reporting timelines. So if I can ask the board to approve the delegation, please.
Do we approve that delegation? I see no objections, so thank you very much for that, Sally. Move on still with you then, board review report.
Thank you. So this paper brings a summary of the discussion that we had at a recent board away day, where we had done a survey of people's thoughts on the effectiveness of the board and looked and discussed some ways that we felt that we could improve how the board works. So these primarily fall in a couple of areas, which is increasing the user voice at the board and away days and links into board members, and ensuring that we get a breadth of staff voices heard at the board, and also a focus on increasing use of data and where possible real-time data as well. So it summarises that discussion and also expands a bit on how we thought we could get the user voice at the board in different ways. So looking for the board to agree that this is a of the discussion and agree it as a way forward, please.
Any observations? If not, we'll agree that on the way forward. I'm also being lobbied for a break, so thank you for that. Can people hear me? Sally's frozen on my screen, or is it me? Matthew, can you hear me?
Yeah.
Yeah, okay.
Yeah.
All right. Okay, well, anyway, they'll approve that and we'll have a break. What are we looking for? If we can come back in 10 minutes. Everybody happy with that? So we'll come back at 1:28. Is that all right? Yeah, done. See you in 10 minutes. Thank you. 13th of PQAC, please, Yemisi.
Thanks, Andy. I'll assume everybody has read the paper, and the majority of what we've discussed has come up in various forms today already. So I'm not going to touch on them. We had Bexley Care do a presentation. It was a really comprehensive presentation. It was really brilliant. And what was great to see is how they've developed in terms of their quality assurance since we started having directorate presentations. It was they had a well-developed QA system. They had a good grasp of their challenges in their directorate, their action plans, their mitigations, their QI. The forward thinking of the directorate was great to see. So it was pleasing. We also had a review of SIs. We reviewed those 8 SIs reviewed in total. And one of the emerging themes was maybe the weakness of safeguarding. It seems to have come up in a few of those SIs. So we've asked for a paper to come back to our next PQAC meeting. Also around SIs, we've continuously had discussions about outstanding actions that haven't been closed. So roughly there are still ongoing, maybe between 60, 70 outstanding actions that some of them date back as far as 2018. So some actions do come off and then new ones are added as new SIs emerge. However, we are looking for as many of them to be dealt with as possible and to be closed. So we're closely monitoring that. And I say, as a committee, I think one of the really positive things is that we now get richer data and deep dives and richer discussions as to items that come up. So we're really pleased with that. And I think our focus now is going to be about dealing with quality issues that occur on the ground that maybe we can't identify through the data that we're given. And that would tend to come through the Improving Lives programme. It's something that Ian previously mentioned in his segment around Heath Ward and potential issues that are going on there. And we know that there are a couple of other wards or services where there are ongoing issues on the front line. So we will be monitoring that to make sure that they are being dealt with and resolved as quickly as possible. So we don't get into this perpetual issue of waiting for the likes of CQC to pick up problems that we may have known about but haven't dealt with in a timely manner. But that's all I was going to say, but happy to take questions.
Thank you, Yemisi. Any questions for Yemisi? If not, we'll go. Thank you very much indeed for that. And I thought it was a really good report, wasn't it, for Bexley? I thought it was really comprehensive. It was very good. We'll move on to QI. Amlan, please.
Thanks, Andy. So again, I'll assume the paper's read high-level feedback. We had a couple of fantastic projects, as usual, presented to us at the committee. I think particularly impressive was the reduction in delays in the hip fracture rehab pathway, you know, bringing down average time to first therapy from 35 days to 8 on average was brilliant, and some patients experienced almost next day continuation of therapy, which was brilliant. The two, I guess, ongoing themes that we are making progress on, and particularly interested to hear feedback at the next committee at the end of this month, are around two particular kind of work streams, I guess. One is around service user involvement that Neil particularly is taking a lead on, and secondly, this issue of how we spread learning between directorates as well when we discover something that has a huge impact, how we spread that learning. So those are the two work streams to be continued for a further update later this month. But happy to take any questions.
Thank you, Amlan. Any questions for Amlan at all? If not, thanks very much for that. We go on now to Business Committee. Jo, please.
Thank you, Andy. So Azra, I'll leave Azra just to give a bit of colour on in terms of the financial results for last year. I think in summary, we landed where those above us wanted us to land, I think. That was a bit of a moving feast at the time, as we know. within that, I think it's pleasing to report that the SLP programs did generate a potential surplus, but we've put that on the balance sheet for future investment. So that was good news, given that, you know, there were quite a lot of changes and we took on various services. I think we had a good result on the valuation because that reduced the value of our buildings and that reduced our dividend, and that should be an impact going forward. So that was very positive, and that helps things. SIP target at the top of the second page of the report, given the arrangements that were in place during 2021, and as Azra has mentioned already, we didn't really make any inroad, not surprisingly, on that. So that, you know, is looming and is likely to be harder on a pro rata basis for this year. We clearly have been spending some time on bids. We talked, I think, on every occasion that we've met for the last 6 months or so about Startwell. Certainly still some ups and downs there, and also on the prisons bid, and had updates on the planning framework for 21-22, and obviously we'll come to that in part 2. But Azra, do you want to sort of give any further colour in terms of the financial results? And what I would say, we did congratulate the team. It's an awful lot of work, and it's still going on, of course, because of audit and things like that, to ensure that you can land in you know, the right position. And so well done to the team, given all the other pressures that are happening.
Thank you very much, Jo. Just one thing, there's a slight update on the financial figures, because after this report was sent through, there was some additional funding that arrived of 870,000. So what that is going to do is to move our 2.1 million surplus that we've reported here before impairments and other adjustments to 2.9 million. So just so that people are aware of that, and we've had letter confirmation from NHS-EI. I think the other element I would just draw out for everybody is we spent quite a bit of time during the year talking about the NHSE retained services payment, which we found a non-recurrent resolution to for last year, and we're going to have a very similar resolution to that for H1 of this year, because it wasn't recurrently sorted in the baseline. So just so that people are aware of that, but the position was actually underwritten via that particular movement. And drawing attention to the COVID costs, as I'd said, the £9.7 million, which is the total year, that was about £1 million less than what our COVID allocation was for that period. So we've been given the same allocation for the coming year, so I'm not anticipating any issues on being able to cover sickness levels, because, to be honest, I don't think the July, well, hopefully with the vaccinations, whatever the expected June-July peak will be when the whole country opens up, should be mitigated by the vaccination, in terms of hopefully people ill enough that they would be needing to take time off. I think it's worth noting that we have had a high usage of private beds. I won't go thoroughly through that position because we've had quite a long discussion. But actually on PICU, we've had the highest level of PICU in March that we've seen since April 2019. I think that probably is an impact of whereabouts we are with the pandemic. And that will be interesting to keep an eye on, and how long that high level is going to be sustained going forward. I wasn't going to raise actually anything else within the rest of the report, but I'm happy to take any questions in the more detailed report that's sitting within the pack.
Thanks very much, Ezra. Any questions for Ezra on that at all? If not, thank you. Anything else, Jo, at all on Business Committee? No, well, again, thank you, Ezra, and your team. Huge amounts of work. Really, really grateful for the energy and effort you and your team are putting into this. Thank you. We now go on to partnership, please, Jo.
Yes, there's a brief summary in the pack. Section 75, those discussions are ongoing. We had thought that needed to be concluded before the beginning of this financial year, but for various reasons that is now sort of being extended. ICS, I think it was come up a number of times. I think the focus very much there was on the sort of financial regime. Happy to pick up any other ICS points either here or in Matthew's report, but at the moment that's where all the focus is. And likewise on SLP, actually, there are no sort of major decisions that we're aware of coming up on the SLP. We do have an SLP Committee in Common meeting next week. But again, there was nothing major. It was more sort of making sure that we were on top of the provider collaboratives and the other services that we took on this year. So nothing much to report.
Thanks, Jo. Anything with regard to the SLP Committee in Common, do we need any sort of pre-meet on that one?
I haven't seen the papers yet, to be perfectly honest, Andy. I don't know if anyone else has.
And Ezra?
So just bearing in mind what's coming through the portfolio board, there's an investment paper that is probably going to be what we would do, I assume, in the Committee in Common. It's not new investment in terms of new services, it's further investment in the programmes we already have. So I don't know, Matthew, whether or not you think, I think that's the only key item that would end up in a partnership Committee in Common meeting.
Yeah, I've got portfolio board at 3:30 today, Jo, so I assume that's the papers will follow from that today. So if you want, I can ask Sue though to get us in a pre-meet.
I think it's useful to have a half an hour pre-meet. You know, we should ask Sue to put them in before every Committee in Common, I think. And then if we find we don't need them, we can cancel them. I think that would be useful.
Yeah, that'd be a good idea. Stephen, are you chairing this one?
Yes.
Right.
Yeah, and I have had a conversation with Jeremy. I think the meeting will be a little bit light, apart from starting the discussions about SLP strategy going forward. So, yeah.
Okay, I suppose it's good that you're in the chair. I'm just wary of anything cropping up in there that we haven't thought about, particularly any new initiatives that we might not have had a chance to discuss. So, Matthew, you'll be able to update us in due course, and we'll get a pre-meet in the diary then.
Will do.
Okay, brilliant, thank you. Anything else on partnership from anybody else? If not, very grateful, thank you. Infrastructure, Suzanne.
Thank you very much, Chair. Like my colleagues, I'm going to take the front sheet as read, just add a couple of comments to what we've said there. The first point is that there was quite a substantial discussion about money, which is coming up under part 2. So I'm not proposing to say anything about this at this point, other than to comment that we're going to be having a discussion at the May meeting of Infrastructure Committee to really pick up on how we orientate ourselves to the new circumstances with the ICS in terms of the controls on our capital expenditure. I'm very grateful to Asra for all the work that she's done this year on sort of managing to come out with quite a good settlement for us. But I think the key thing going forward is that we look at the underlying principles for the allocation of the capital spend, rather than it, and which probably go beyond being purely financial questions into how we serve our population. There was a presentation on the ICS digital strategy, which was perhaps a bit less informative than I had hoped, because it was a presentation about the strategy to come rather than the strategy itself. However, they were making the right noises about seeking representation on their kind of governance arrangements for the digital strategy. And so Alison Furs will be taking that forward, because I think it's really important that we have a voice at the table, and I'm able to share some of the innovations and experience that we can offer, as well as being able to position ourselves within the ICS. And the other thing, perhaps just to add about what we weren't able to look at in May, so there was quite a busy agenda, so we deferred our discussion about environmental sustainability. Sorry, this in the April meeting. This is then going to come forward again in May, and it's going to be quite a significant issue, I think, because there's no doubt that if we're going to meet our net zero ambitions for the NHS, there is going to have to be some capital investment, and that is probably going to take a certain amount of follow through, shall we say, with the ICS. So there are sort of issues which are on the agenda for May, which are quite strongly strategic in their orientation.
Thank you very much indeed for that, Suzanne. Any comments, questions on infrastructure from any colleagues? We'll obviously talk about money in part 2. If not, I'm very grateful. Thanks very much. Audit and risk, please. Sorry, workforce, please, Nina.
Thanks, Andy. Again, I'm going to take the report as read, but there were just a couple of things that I wanted to call out. Rachel has touched on Operation Cavall, which is the partnership between us and the Met Police. And I think that the one point that I just want to make here is it's not that long ago that we had a discussion around this table about how staff had become used to wearing almost as a badge of honour some of the violence and abuse that they were putting up with. So to have got to this stage in relatively short order, I'm very proud of the team for the amount of work that they've put in and the strength of the partnership that has been formed. We also talked about the Building a Fairer Oxleas work stream, which has been underway for a year now. And again, another call out for the work that's underway here involves massive cultural shifts. So it's not the area where we can expect to turn the dial incredibly quickly, but I want to commend the work that is taking place and the focus that has been very much on ensuring that if you are a member of staff, you are seeing and feeling a difference in the engagement that you have on a week-to-week basis, which I think is really important to maintain. We talked about the res equality data, which unfortunately has gone backwards, and we are having a deep dive at the next workforce committee on why there continues to be an overrepresentation of BAME staff in disciplinary procedures. There are a number of strong sentiments around the table, including amongst workforce NEDs, that we really need to get under the skin of this. And we are looking to do that, as I say, at the meeting in a couple of weeks. We talked about the leadership development programme, how the focus is very much on creating and growing the future leaders of the organisation, as well as ensuring that our managers are well equipped for the demands of their role. And the last thing I want to call out, which for me was actually a really powerful part of the last meeting, was a presentation that lasted about 20 to 30 minutes that was very rich in both insight and candour from the chair of our new mental health staff network, which replaces the lived experience network, and brilliant quality of discussion. But I think for me, the real hope was that COVID will allow things to open up in a way so that people actually feel more comfortable, genuinely more comfortable about talking and sharing their experiences of mental health and coming forward to do so. And I'm very pleased that we will be welcoming Abby to our committee going forward, because I think there is real value in having dialogue around medical workforce issues and some of the issues that are very helpfully flagged up to us by the Junior Doctors Forum. Happy to take questions, Andy.
Oh, that's good news. You've got Abby coming along. It was my experience in the past that we used to get something from the junior doctors once a year, which was often just a bit of a surprise, and then without really seeing much of them for the rest of the year. So it's a really good move. Thank you. Anything from anybody else on workforce? If not, there's an awful lot there. I'm very grateful. Thank you very much indeed. Audit, please, Steve Dilworth.
Thank you, Andy. Apologies that I've had to turn off the camera, but my battery is starting to get to a very low level. But notwithstanding that, just a couple of things to report. First of all, freedom to speak up. The internal audit report gave significant assurance with just some minor recommendations. The only one medium recommendation, which was really about sharing the action log between ourselves and the Guardian service, and also sharing all the detail on staff concerns. But basically, for a relatively new service, I think both for ourselves and KPMG, that was a good result and a good reflection on the work of Rachel and her team. Local counter fraud specialist, 2 cases that have been under investigation. To give you a scale of it, one is for a loss of £1,900 and the other is £9,600. One we are pursuing through the employment agency, and the other one we're in negotiation with a member of staff to recover those costs. I'm sorry, my screen just went off there. We had a full report from the Infrastructure Committee, which a very detailed report from Suzanne. Fairly self-explanatory there. Suzanne, I don't know if there's anything you want to comment on. No? Okay. Thematic risk analysis. I mean, Sue-Owen has done some fantastic work here, I think, on giving us much more detailed information on our risks and also in a more presentable way. So I want to thank her for the great work she's done on that. You can see there, and we touched on it earlier in the conversation today, there was a discussion about the longevity of risks and just clarification that certainly for some of them, as I said earlier, although they've been on for 2014, the risks themselves have considerably changed. And apart from that, there's nothing else I would want to report.
Thank you, Stephen. Anything for audit from anyone at all? If not, I'm very grateful. Thanks very much indeed. We'll go on now to the board visits, and in the usual way, we'll keep it brief, please. We've all got the report, and we'll go in the order in which they are in the papers. So, Stephen, you did a visit to Betts.
Yes, Betts Ford has been giving us a little bit of concern, partly because of due to COVID arrangements, they've been lacking in on-site senior management. Also, they've been having they have had a few complaints over the last 12 months. And coupled then with all that, there was a strong resistance to body-worn cameras, which, given the other two items at play, certainly for myself and Matthew, and I think Lorraine, we just were starting to get a bit of a bad feeling. So it was very good to go there. They certainly the new managers they've got working on the ward seem to be getting a very good grasp of staff issues and giving the best service that we can to our patients. But I was particularly pleased that the lengthy discussion we had in body-worn cameras, which started out with lots of reservations, the negative aspects of having cameras, and indeed some good points that for some patients they actually could escalate their state. But generally, by the end of the discussion, everyone accepted that there was more benefits than disadvantages, and I think that allayed a lot of our concerns. So so I felt a lot better at the end of it, as I'm sure did Ian and Lorraine. But I think certainly this would be a very good case for when we're back to make physical visits. Betts Ward will be high on our agenda to go back and see it.
Grateful. Thanks very much indeed. Anyone else wants to comment on any of these other people's visits on the way through, then please do. Joe, you went to the spa.
You went to the Greenwich Spa. Ian came too. It was a very positive visit. As you can see, I think all actions are in hand. I think all the actions that were discussed were very reasonable, actually, reasonably presented. I mean, just to say, this feels like a really strong team with a good leader. And, they've really adapted really well to COVID in terms of working flexibly. And of course, it's not just the way they're working. They're dealing, as you can see, with over half a dozen different teams, all of whom have had to adapt the way they're working, the way they're seeing clients, and that has changed over time as well. So that absolutely impacts on the work of the spa. But they were enthused and positive about it all, which was great to see.
That's really interesting. I remember seeing them a few years ago when things were fairly new.
Yeah.
I was just looking, are they going to carry on with this split working from home and office?
Yeah, I think they plan to do some of that. They have a kind of a rota with a core team in at any one point in time. They have had issues in the past because they're split over, I think they're a combination of two teams. They're split over two locations. So they're hoping that with the new way of working, that problem goes away, but it's not quite there yet. Yeah. But they definitely see some advantage in terms of the hours they're covering as well, in terms of having some people working at home, but it's on a rota, so everyone is coming to the office now at certain times.
It looks very positive. As I say, it was quite bouncy in the beginning, but good.
Yeah. Can I just mention else? We also did a visit this week to the Children's Vaccination Service, and the report for that will come through in next board meeting. But just to say, one of the things they're picking up is that in some areas, vaccination scepticism from the parents is impacting on the level of vaccinations for the children. And, you know, there is a bit of a plea there for back to NHSE, who are the commissioners, and I think we're waiting for them to renew our contract. But there needs to be some real sort of health investment there, because otherwise the COVID skepticism could, you know, end up causing potential measles outbreaks and meningitis and things like that. So I think I just thought it was worth mentioning that.
Yes, thanks very much, Jo. Suzanne, did you want to come in? Suzanne, did you have your hand up?
I'd actually had my hand up in relation to the previous one, but it's a point I can cover. I'll raise it internally.
Okay, thank you. Right, next one is the IACT, and Nina, please.
This was a brilliant visit, really insightful, actually. They are a very strong team. A lot of them have actually been together for 11 years, with a number of staff having actually joined Oxleas and then worked their way up to senior level now. Very strong team, very good at retention. For me, the one point, we talked about two interesting themes, one of which was potential structural barriers to access, and those were things like language interpretation. They've been very creative in terms of how they've worked around those, but there are still a number of issues around access within the community, whether that comes from the BAME community and whether that's language-based or whether it's technology-based, impact on older adults, impact on veterans. And I know that Helen is taking that forward, the point around inequity of access and outcomes with Greenwich Public Health. I think the point around structure of the team itself was that how we structure the teams and the lack of an 8A leading the BAME work stream has potentially resulted in missed opportunities that impact both from a staffing and both from a patient perspective. So again, that's something that Helen is going to be taking forward, and I've spoken to Rachel C. Evans around what we might be able to do on that from a workforce perspective as well. So overall, very insightful visit, and pertinent to note that their referrals have grown from 35 a week to 190. Part of that is because clearly the impact of the pandemic, but part is also because hypothetically the sense that people have been kind of holding on to their issues until they've been able to come through the pandemic. Kids have gone back to school, they're able to access services a little bit more readily. So insightful on a number of levels.
That's really, really reassuring. Thanks ever so much, Nina. Stephen, Mental Health Liaison Team.
Nothing much to add here, really, Andy. I think the most interesting development for them is around the health assessment area at the PRU, which is coming on stream. So as and when that's developed a little bit more, we should be going back to them. But as you see, it was a rather limited visit due to various restrictions, and they were having a busy day in the emergency department. So nothing really more to add, and they had no issues they wanted to raise with us.
Build. What's happening on the new build within ED, Matthew? Are you with us, Matthew?
Within ED at the PRU. At
the PRU, yeah.
Yeah, it's ready for. I think it's ready for us to start using it in June if we can just agree the funding with them. We put in 250 grand, and we're asking for the other 250k from the ICS. I was there last week speaking to Jonathan Lofthouse. It's as a location, it's on the first floor of a 2-story temporary building, which isn't perfect for our requirements, but it's certainly better than what we've currently got there. So the aim is to get it started over the course of the summer. Recruitment may take a bit of a while, so I'd imagine it'll be fully operational by the autumn.
And the staffing setup?
Lorraine's still negotiating around that because we haven't got the full funding envelope we wanted. So there's a bit to go on that to make sure it's fully funded. Lorraine doesn't think it'll be particularly difficult to recruit to. She thinks they're quite attractive posts because it's a bit like inpatient work, but you're not actually carrying the care responsibility and the caseload with it. So she thinks we'll be able to pick some of that, some of those staff up. But we will be going out into it. The risk is we'll end up potentially taking people out from other teams of our own into there, via bank shifts, etc. So that's why, rather than saying we're going for June for full opening, it's probably going to be more likely to be September by the time we've worked through all the workforce implications.
Yeah, it'd be good to know a bit more, given the history of some of our activities around this. So a visit out there for NEDs would be great at some stage.
Yeah, I'd have thought I'd be thinking more late summer, autumn, Andy, than any earlier than that in terms of really seeing it working fully.
Okay, grateful, thank you. Suzanne, please.
Thank you. I'm sorry about this, Andy, but my laptop's playing up and I wanted to ask a question about Nina's report and I couldn't get my hand up quick enough. If you don't mind me going back to that, I was just really struck at the part of Nina's report that dealt with the impact of remote consultations on Black and minority ethnic groups. I didn't want that to sort of pass without further comment. I mean, I'm concerned that perhaps what Nina is picking up here is the tip of a slightly larger iceberg. And I'm wondering, whether something is going to be taken forward here by anybody.
Can I respond to that, Andy?
Yeah, please, Ina, thank you.
The short answer is I think we need to establish how we're going to look at this across the trust. I would be astonished if it was an issue that was restricted just to IAT. What I did welcome was the candour with which they talked about it. There was an enormous amount of insight, of passion, people who were really concerned about not having been able to access, or their patients not having been able to access services, and the various barriers that are in place, which are probably easier for us to address on a trust-wide basis. But I wonder what more needs to be done with the local community and working hand in glove with some of the councils as well. So I don't know whether colleagues have got suggestions around what more we could be doing.
Ian?
I mean, I think it's really helpful to highlight it. I think I said earlier that it's very clear. It was very clear to me outside of IAPT in terms of mental health services that a reliance on technology in some interactions with service users has disadvantaged some groups, and the concept of digital poverty. And I think there's clearly and then an additional complexity about how that kind of plays out within certain communities. I think what's interesting about IAPT is that I suppose the received narrative is that they are a service that has successfully moved all of their activity onto a kind of virtual platform or telephone platform, and that has helped the service to increase its coverage, which is one of the things that they're kind of managed on. So I think to have this kind of detail that it's not quite played out like that is very helpful, because there will be a lot, whatever else happens, there's going to be a lot of focus on IAPT across South East London, but obviously for us in Greenwich. So I think we need to we need to explore this a bit further. I know that Rachel has highlighted that one of our colleagues down in the service has got some ideas around improvements that they want to share, and I think it is linked to working with BAME communities. So I think we need to explore that a bit further, really. So I'll take that back through Helen and see what we're going to do.
Thank you, Ian. Nina, did you want to come back on that?
I just wanted to make 2 points on that. I think tech and digital and what Ian has touched on was from what colleagues were saying in that session was part of the problem. I think there were 2 additional components. One was how do we structure ourselves as a service and tailor our structuring depending on where we are providing our services to best access the communities that we're looking to reach. And there was a colleague who shared a brilliant example about the outreach work that has been done to improve vaccine take-up within some local communities, using mosques, using community centres, using various other community settings, and a plea for why can't we move towards using almost a one-stop shop model, because a lot of the people that we're trying to reach in those communities wouldn't necessarily put themselves forward, or there would be stigma attached to accessing the sorts of services that IAPT provide, but putting them under the umbrella of a kind of one-stop shop where you pop in and you get your vaccine and you access dietary advice and you do, makes it much more accessible. And there was the sense that because we didn't have a band 8A, that we were missing an opportunity to be able to put heads together and come up with some more creative solutions like that, which would be within our gift, but clearly working within the community. There was another very powerful point around data and how do we structure our services in a way that reflects the data that we're being fed back. What analysis of that data do we do? And I didn't realise that we don't actually collect data on the number of non-English speaking referrals or the impact of the services that they are referred to. So we're doing the stuff that we're doing, but we're not measuring the outcome or the impact that that's having. And that is different, or my sense from the conversation was that that's different from how other communities and non-BAME communities have data measured. So I don't know whether there's some further thinking that we could do around that.
Rachel? Rachel, I was just wondering, this just can't be unique to us, can it? And there's trusts like ELFT.
Yeah, so I think it's probably one that we need to be exploring as part, with Ian as the lead for the service user inequalities side of what we're doing, and very happy to understand a little bit more from Nina and Jane from that visit about exactly the issues that were raised and have a think through how we can best incorporate that insight, I think, into how we take forward that strand of the strategy.
Yeah, thank you. Suzanne, please.
Yeah, there's just that there is a connection with the New Ways of Working project, and I'm actually looking at Asra here because I think, Asra, you're still chairing that group, aren't you? So this is going to come back to Infrastructure Committee at our May meeting, and I think one of the things that we did want to explore in particular is the impact of new ways of working on patient experience and the outcomes that patients are getting. So I think there does need to be a little bit of a focus on this, and perhaps a conversation both in Infrastructure Committee as well as in other places, which Asra would be able to sort of stitch together as the exec.
Just to say, probably the best lead on that is actually Alison. So it's a joint piece. They come to TPEG, but actually the work is being led by Alison and Rachel T. So I think they'd certainly be able to feed some of that information in.
Yeah, I suppose I'm trying to think, how do we capture this as some sort of action? Can someone assist me with this about how we might say who's going to do what by when and what's the issue? I'm not entirely sure I've captured in my own head what the issue is and what we think we might do about it. Can anyone assist me on this? I'm going to come back to you, Suzanne, and say, what do you think the issue is here and how we might take this forward?
Well, I do think there's an issue here about the interaction between technologies and people, and we're seeing it playing out in a particular way in relation to our diverse group of service users. So I certainly think it's something that we should be picking up and discussing at the Infrastructure Committee, because our focus isn't just on hard stuff, it's as much on the soft stuff, is, you know, how the technology shapes the services that we're providing. So I think that would be one place to do it. What I'd quite like to do, if you don't mind, is to just have a bit of a think about some of the points that Rachel has raised, that Nina has raised, and perhaps a correspondence with Ian and Rachel about a way of making sure that this issue, which has got several dimensions to it, gets covered off in the right places.
Yeah, I suppose that's what I was wrestling with. I think there's a lot of issues here, isn't there? You know, around the whole of the disadvantaged groups, how they play into modern technology. And I was just trying to think about what is it. So it was really helpful. Thank you, Suzanne, for having a think about that, and perhaps come back to us, and we might make some amendment to the minutes to say, you know, this is what we think the issue is, and this is where we think we're going to do something about it, and who thinks we're going to take this forward. Because I was just slightly worried at the end of that item that I wasn't quite sure what it was and what we thought we were going to do about it, which is always a bit interesting when you come back to the next meeting and you can't remember, you know, who was going to do what by when. So is that okay?
I'm happy to have an action point against my name here that I will follow up with, I believe, Rachel, Claire and Ian, and with Alison Furzer as well, in terms of the new ways of working piece that we're looking at.
Yeah, that'd be great. Thanks ever so much. That's really, really helpful. Thank you. Council of Governors update, you've got the paper there. Is there anything anyone would like to raise on that? As mentioned earlier, it'd be really good to have something on Chrome Restraint at the Council of Governors meeting in due course. If there's nothing else on that, while we're talking, Governors, Sue Salter, are you still with us? Are you happy that all the questions that you've asked have been covered?
I think they've been covered. Thank you very much.
Well, thank you. I thought really good questions. It's quite interesting that you come to those, and we in parallel have come to the same discussion about the need to go through the BAF in some detail, which we did. So I'm very grateful for your intervention on that. Is there any other business from anyone else? In the absence of that, I shall call part one to an end. Thank you, Steve, and we'll end the broadcast of this meeting now.